also. And when women looks at its health during the reproductive age group till the child family is not complete, the more focus is on the obstetrics part. Even the government hospitals are more focused on obstetric services. The gynec services, our attention is there, but not to that extent, because we are still struggling with high maternal mortality ratio. So reproductive health has been given attention to some extent, but more needs to be done. But when the woman gets married and her reproductive span starts, then they come across with different problems. The commonest is, of course, RTI, STI, and the menstrual disorder. And we have trained our Ashas and ANMs. We had organized Mahila Swasth Shivir, and we have given them the questionnaire that if you come across women with menstrual disorders or with prolapsed uterus, because these were the conditions which we were finding in the OPDs, and they were coming in the last stage of precedentia where we were unable to preserve the uterus. And of course, RTI, STI, they were just going to the quest. So we have given them the list of questionnaire, and the women were referred to district hospital. Because if we look at PHCs where male medical officers are there, we have trained male medical officers in management of RTI, STI. There is a syndromic approach, but still the gamut of investigations are not available. So in district hospital, we have started a designated gynec clinic by the name of Roshni on every Wednesday. So that the focus is there on gynec services also. And the women can walk in on Wednesday. They can have their investigations done. Now we have hormonal profile. We have all sorts of investigation which is available in our hospital. The women also come across with the problem of infertility. The family planning or the family welfare deals with the limitation of family, but also with the women with problem of infertility. So that is also quite prevalent. So we are managing those women also. The indication for IUI and IVF being evaluated by our gynecologist of district hospital, and then we refer to private center. And Madhya Pradesh is the only state who has accredited private ART centers for under Ayushman Bharat for management treatment. So we have some hospitals. And one more thing I would like to say before handing over to you. We are doing screening of HIV, syphilis, and hepatitis B at sub-health center level, which has been designated as health and wellness center. We have provided refrigerator to all the sub-centers so that cold chain is maintained. And now we have nearly 11,000 centers which are providing these services. We have trained our CHOs for doing so.
Excellent. Thank you very much for this very important input, Archana ji, from where we draw three important points. One is the focus is totally on her reproductive career. So infertility hole you have tied up, and that is also a worthwhile service that is being offered. But mainly pregnancies, high-risk pregnancy, delivery, and infant maternal mortality, that's the main focus, and you've honestly admitted that. So that is that's a huge chunk of focus. But there is a spotlight. Roshni padti hai, Roshni ke zariye every Wednesday. That is the limited span that the women has to access. And the third important point you brought is about the male medical officers. There may be culturally many women who are very sensitive to the fact that somebody who is actually going to deal with her gynecological problem, they generally look for women doctors, which is still quite the mindset in large parts of our country. So we will try and figure out what we need to do about them. But before I go to Kavita as planned, I think Dr. Tarun Chaudhary from Rajasthan has an emergency and needs to go. So Kavita, just let me direct the question to हिम फर्स्ट। तरुण सर, अभी एक मुद्दा जो है मेल मेडिकल ऑफिसर्स, तो प्राइमरी हेल्थ केयर पे दे लुक ओनली इन अ लिमिटेड नैरो स्पैन के जरूर, चलो भाई इसके डिलीवरीज हो गए तो छुट्टी, बाद में वेर एवर शी वॉन्ट्स टू गो, वॉट एवर शी हैज, उनको अपना अपना निपटना पड़ेगा, और शी हैज टू गो ऑल द वे टू डिस्ट्रिक्ट हॉस्पिटल टू गेट हर केयर. दैट इज पॉइंट नंबर वन. एंड सेकेंडली, any policy, any insurance, anything that covers a woman beyond her reproductive age, इसके बारे में आपका क्या चिंता है? Into Rajasthan, because Rajasthan, even every auto driver and the car, the drivers say that हाँ इधर तो अच्छी भामाशाह and all very nice insurance schemes are there, and हमको बहुत सहूलियत मिलती है पब्लिक हॉस्पिटल से. लेकिन इस मुद्दे पर डू women know that they can reach out, and is this really the happening on the ground कि उनके केयर के लिए आपका क्या सोच विचार है, और आज के दिन में आप क्या कर भी रहे हैं?
थैंक यू मैडम. बेसिकली मैं दो तीन आपकी बताई हुई जो बात है उनके साथ साथ कुछ और चीजों को भी रेज करना चाहूंगा
जी.
बेसिकली मैम, हम एनएचएम को डील करते हैं, जो भी पैनलिस्ट आपने बुलाए हैं जिसमें अर्चना मैडम भी है और बाकी ऑफिसर्स को मैं डीपली नहीं जानता. मैटरनल हेल्थ मींस हमारा जो वर्क एरिया है वो कंसेप्शन से 42 डेज तक मोटे तौर पे रहता है
जी.
हम लोग लिमिटेड मैन पावर के रिसोर्सेज के साथ में काम कर रहे हैं और पब्लिक हेल्थ जो हमारा डिवीजन होता है उसके साथ में कोलैबोरेट करते हुए काम करते हैं, है ना. हिस्टेरेक्टोमी वाला जो पार्ट आ रहे सिजेरियन पार्ट हम डील करते हैं. हिस्टेरेक्टोमी पार्ट जो है वो पब्लिक हेल्थ पार्ट में, और जहाँ पब्लिक प्राइवेट हॉस्पिटल्स मेनली इन्वॉल्व है इस चीज के अंदर, वहां पे क्लिनिकल एस्टेब्लिशमेंट एक स्ट्रॉन्ग मैनर में इम्प्लीमेंट होना जरूरी है. सब लोग जान रहे हैं एनएफएचएस 5 का डाटा और उसका आउटकम स्टडी, और दूसरे अगर लिटरेचर्स मैंने पढ़े हैं पिछले 3-4 दिन में, बातें निकल के आ रही है कि ये कहीं ना कहीं वुमेन की हेल्थ रिक्वायरमेंट के साथ साथ कहीं ना कहीं पे सर्विस डिलीवरी करने वाले जो हमारे सेक्टर्स हैं उनका भी इंटेंट इसमें ठीक नहीं है. यही वजह है कि 70% हिस्टेरेक्टोमीज जो है प्राइवेट सेक्टर में हो रही है, 30% गवर्नमेंट सेक्टर में हो रही है. गवर्नमेंट सेक्टर के जो हमारे सर्विस प्रोवाइडर्स हैं वो थोड़े से जुडिशियसली उसमें अपने काम को कम करने के हिसाब से देखें, या एक एथिकल पार्ट पे देखें जिसमें फाइनेंशियली बहुत ज्यादा इन्वॉल्वमेंट गवर्नमेंट सेक्टर के ऊपर किसी भी डॉक्टर का सैलरी के अलावा नहीं होता, तो वहां पे जस्टिफिकेशन के साथ में काम हो रहा है और ये संभावनाएं हैं. ओवरऑल कंट्री की जो हमारी स्थिति है वो 3.3% हिस्टेरेक्टोमी है, बट जहां जहां जो स्टेट्स रहे लाइक आंध्रा 8.7%, तेलंगाना 8.2%, बिहार 6%,
जी,
अदर स्टेट्स ऑल्सो, जहां पे सोशल सिक्योरिटी वाला जो इंश्योरेंस पॉलिसी वाला जो पार्ट जितना एम्पावर्ड था बरसों से, उतना उसमें रिफ्लेक्शन दिख रहा है कि हिस्टेरेक्टोमीज ज्यादा हुई है. जरा सी प्रॉब्लम हुई और हिस्टेरेक्टोमी हुई. रूरल अर्बन को अगर अपन देखते हैं तो अर्बन एरिया की जो वुमेन है वो ज्यादा लिटरेट है और ज्यादा कंसिडर करती है कि यूट्रस हिस्टेरेक्टोमी कंप्लीट या पार्शियल जो भी है, कुछ प्रॉब्लम्स या इश्यूज उसके होने वाले कॉम्प्लिकेशंस को समझती है. रूरल वुमेन का जो है इसमें अच्छा खासा परसेंटेज है, ये भी अपने आप में एक इश्यू है. जहां तक मेल डॉक्टर का, जो डॉक्टर अर्चना ने बोला कि फील्ड में मेल डॉक्टर्स ज्यादा हैं, वो वुमन अपनी इस तरह की प्रॉब्लम्स को ज्यादा एक्सप्लोर नहीं कर पाती हैं, बिल्कुल सही बात है. लेकिन हमारे पास में इतने फीमेल डॉक्टर लाना जो प्राइमरी लेवल पे भी अवेलेबल हो, ये बड़ा मुश्किल है, और ये आने वाले 30 साल बाद की बात है. तब तक तो हम कितना ही नुकसान हो चुका होगा या कितनी चीजें आगे बढ़ चुकी होगी. तो एज ऑन टुडे अगर हम पॉलिसी में ये इन्वॉल्वमेंट करते हैं कि मेल डॉक्टर, यस ही इज क्लिनिकली साउंड एंड इन द प्रेजेंस ऑफ फीमेल नर्सिंग स्टाफ, जरूरी चीजें एक्सप्लोर करते हुए हम एक छोटा सा उसका वाया मीडिया निकाल सकते हैं, वो किया जा सकता है. पॉलिसी में हमें बहुत इंप्रूवमेंट करने की आवश्यकता रहेगी मैम, कि इंश्योरेंस पॉलिसी वाले जो पार्ट हैं उनके अंदर कहीं ना कहीं पे राइडर्स लगे, कहीं ना कहीं जस्टिफिकेशन हो. जो हिस्टेरेक्टोमी गायनो खुद डिसाइड करती है कि इसकी हिस्टेरेक्टोमी करनी है, या क्लाइंट ने डिमांड करी, या प्राइवेट के डॉक्टर ने उनको एम्फेसिस किया, तो कहीं ना कहीं सेकेंड ओपिनियन भी उसमें मैंडेटरी होना जरूरी है. हम कहते हैं कि जहां ओपिनियन 1 से 2 में जाता है तो वहां पे उसका डिसीजन थोड़ा ठीक होने की संभावनाएं होती है, ये होना बहुत जरूरी है. तो कुछ इसमें राइडर लगेगा कि मनमर्जी नहीं चल सकती, जरूरत है वो चीज करें, पेशेंट के हित में करें। तीसरी बात, मैं कह रहा हूं कि जब पीसीपीएनडीटी पूरे कंट्री में चल रहा है
जी
और हम कंसेप्शन को यूएसजी के टाइम के ऊपर जरूरी पैरामीटर्स के साथ में रिकॉर्ड रखते हैं, ऐसे ही हिस्टेक्टोमी से पहले भी यूएसजी होते हैं ऑलमोस्ट 90% या 100% या 80% वट एवर इट में भी। तो क्या हमें यूट्रस का यूएसजी नॉर्मल या ग्रेविड दोनों ही कंडीशन में हमें डिटेल डाटा रखना जरूरी होगा, जो हमारे पीसीपीएनडीटी एक्ट के अंदर प्रोविजंस बने हुए हैं उसके अकॉर्डिंग। क्लिनिकल एस्टेब्लिशमेंट या कोई मैंडेट में ऐसा दिया जा करके अगर ये मैंडेटरी हो जाता है तो निश्चित तौर पे एक स्टेट लेवल पे जिस तरह से इस तरह के केसेस में ऑडिट होती है उस तरह से ऑडिट अगर होता है तो निश्चित तौर पे थोड़ा सा लोगों के दिमाग के अंदर ये डिसीजन लेने से पहले कुछ क्लिक करेगा कि शायद मुझे जुडिशियसली काम करना चाहिए, मैं कहीं देखी जा सकती हूँ या मुझे देखा जा सकता है, तो डिसीजन में थोड़ा सा फर्क पड़ेगा, मेरा ऐसा सोचना है। तीसरी चीज जो हम कह रहे हैं कि मैटरनल हेल्थ यूनिट से पूरी आप बात कर रहे हैं, तो हम लिमिटेड जो हमारा पॉपुलेशन एरिया, जैसे राजस्थान में 17 लाख मेरे पास में क्लाइंट है और 4 मेरे पास में स्टाफ है। अगर हम वुमेन हेल्थ की बात करते हैं एक मैटरनल हेल्थ यूनिट के में ऑफिसर से, तो 50% पॉपुलेशन पूरे स्टेट की उसके राडार में आ जाती है। और आप देखें कि उसके अंदर इंटरवेंशन बहुत मुश्किल होता है। तो जहां पे पब्लिक हेल्थ के सेक्टर में जो ऑफिसर्स हैं, हिस्टेक्टोमी मैटरनल हेल्थ का पार्ट नहीं है, फैमिली प्लानिंग का पार्ट माना गया है। एनएफएसएस 5 के डाटा में आप देखिएगा, है ना, लेकिन फैमिली प्लानिंग को नाम भी नहीं लिया आज की तारीख के अंदर। आज की कोई इस कॉन्फ्रेंस में कोई फैमिली प्लानिंग का ऑफिसर नहीं बैठा हुआ है
जी।
तो ये भी हमारा कहीं ना कहीं थॉट सीधा सा हिस्टेक्टोमी की बात आई, मैटरनल हेल्थ डिवीजन को आप टच कर लें, मैटरनल हेल्थ मिनिस्ट्री ने इसकी गाइडलाइन जारी कर दी तो मैटरनल हेल्थ के ऊपर सीधी बात आ गई। तो मैं ये नहीं कह रहा हूं कि हम काम नहीं करने का बहाना देख रहे हैं, हम पॉलिसी में गैप की बात कर रहे हैं।
जी
काम तो करना ही पड़ेगा जब तक गवर्नमेंट सर्विस में है। तो ये 2-3 चीजें बहुत जरूरी है मैम। जब तक हम स्ट्रिक्टली इसमें कोई लॉ बनकर के, चाहे सुप्रीम कोर्ट इसमें जो डायरेक्शन जारी किए हैं उनकी बात करें, वो भी नौबत क्यों आई। हिस्टेक्टोमी एक दिन में तो बढ़कर के इस लेवल पे नहीं आई, सिजेरियन भी एक दिन में बढ़कर के इस लेवल पे नहीं आए। तो ये ग्रेजुअली बढ़ रहे हैं और हमें अभी से ही, आप ये चर्चा के माध्यम से ये बातें रेज हो रही हैं, तो डेफिनेटली अभी से ही हम चेक एंड बैलेंस के साथ में चलेंगे तो नो डाउट कि आने वाले नुकसान को रोका जा सकता है टाइम पे। और जहां तक जैसे अर्चना मैडम बता रही थी कि नॉन रिप्रोडक्टिव एज ग्रुप के अंदर अगर मान लो यूट्रस को रिमूव करना पड़ता है, मेडिकल साइंस में एमबीबीएस में पढ़ा था कि जब बाल सफेद ग्रे होने लगते हैं तो मेल को फैमिली कंप्लीट होगी तो प्रोस्टेट और मदर को यूट्रस निकलवा लेना चाहिए, क्योंकि आगे जाकर के एक इस तरह का हमने लाइन अंडरलाइन करके हमारे सब्जेक्ट में पढ़ी है, वो बात मेरे आज भी दिमाग में है। तो ये थंब रूल जो है कहीं ना कहीं पे मूव करता है कि हम थोड़ा जो है हमारे क्लिनिशियंस भी इस लाइन को ही फॉलो करते हैं और ये बात आती है। तो यूट्रस को प्रिजर्व करना एंड ओवेरी एंड उसके हार्मोनल इम्बैलेंस को पहले से ही गड़बड़ कर देना, और वो लेडी 40 साल में ही अपने मेनोपॉजल पार्ट के ऊपर बॉडी को चेंज करते हुए उसका लिपिड प्रोफाइल चेंज हो जाएगा, देन हाइपरटेंसिव होने के चांसेस हैं, नो डाउट मल्टीपल हेल्थ कॉम्प्लिकेशंस। एक कंप्लीट हिस्टेक्टोमी के साथ में हार्मोनल इम्बैलेंस के साथ में सारी चीजें होने की चांसेस हैं, और इसमें जो ध्यान दिया जा रहा है वो बिल्कुल जरूरी है। साथ ही साथ हमें ये देखना पड़ेगा कि हमारे ऐसे कंट्रीज लाइक यूएस, यूके हाईएस्ट इन द वर्ल्ड हिस्टेक्टोमीज पे हैं। सिजेरियन की बात करें तो इंडिया के बाद दूसरे जो कंट्रीज हैं 70% तक हैं। ब्राजील आप देखें, दूसरे स्टेट कंट्रीज आप देखें, तो वो लोग बहुत दूर तक चले गए हैं ये गलती करते हुए, और हम टाइम पे देख रहे हैं तो शायद ठीक कर पाएंगे। तो मेरा ये था कि मैम इसमें प्राइवेट आपके जो फॉक्सी और दूसरे ऑर्गेनाइजेशंस के लोग हैं उनका माइंडसेट थोड़ा सा क्लियर करना जरूरी है कि हमें एथिकल पार्ट के साथ में चलना पड़ेगा। पैसा जरूरत का के लिए होता है, लेकिन पैसा किसी की हेल्थ के कॉस्ट पे हम पैसा नहीं कमाना चाहिए। सीधा सीधा इसमें साफ लग रहा है कि इंश्योरेंस पॉलिसी वाला पार्ट पैकेज में मिल जाता है। दूसरा, निश्चित तौर पे सर्जिकल प्रोसीजर के अंदर प्राइवेट इंस्टीट्यूशन को ज्यादा पेमेंट्स मिलते हैं, गवर्नमेंट फैसिलिटीज को नहीं मिलते हैं। प्रोविजन सभी जगह है, ऐसा नहीं है कि गवर्नमेंट फैसिलिटीज के अंदर प्रोविजन नहीं है, वहां हिस्टेक्टोमीज नहीं होती, आवश्यकता के अनुसार होते हैं, लेकिन रेशियो बहुत डिफरेंट है। आज हमारे गवर्नमेंट फैसिलिटीज के नंबर ज्यादा है सर्विस प्रोवाइडर के प्राइवेट के बजाय। लेकिन तब भी परसेंटेज में बहुत 70-30 का फर्क है। तो प्राइवेट ऑर्गेनाइजेशंस के डॉक्टर हैं, हमारी मेडिकल कॉलेज के जो एक्सपर्ट्स हैं, गायनोज हैं, उनसे भी बात हुई। उनका ये कहना था कि हम सिंपल मेथड से भी, अगर लाइपोमा है या लियोमायोसिस वगैरह है, तो हम विदाउट हिस्टेरेक्टोमी भी उसको रिमूव करने की कोशिश करते हैं। लेकिन प्राइवेट वाले तो डायरेक्टली हिस्टेरेक्टोमी में जाते हैं, और ये बात फैक्ट भी है। तो ये 2-3 इनपुट मेरे थे।
जी।
तो थोड़ा सा पॉलिसी में चेंजेस और थोड़ा पीसीपीएनडीटी वाले पार्ट के ऊपर तो इसको लीगली स्ट्रॉन्ग बनाने की जरूरत है, और एक कमेटी डिसाइड करे। प्लांट सर्जरी है, इमरजेंसी सर्जरी तो नहीं है, मोटे तौर पे प्लांट सर्जरी ही होती है। तो हम डिसीजन में अगर 2 घंटे लगा लेते हैं तो भी हो सकता है कि 10 में से 2 या 3 केस विदाउट हिस्टेरेक्टोमी काम किए जा सकते हैं। तो 3-4 सजेशन मेरी तरफ से है। थैंक यू मैम।
या थैंक यू डॉक्टर तरुण, क्योंकि आपका इतना गहरा सोच विचार में हमको भी आप सोचने पर मजबूर कर लिए हैं, विच इज वेरी वेरी थॉट प्रोवोकिंग। क्योंकि आपने जो सभी पूरे स्पेक्ट्रम के बात बताए, देर आर 2-3 इंपॉर्टेंट पॉइंट्स इनके कहने पर भी। वन इज दैट डेटा इज इम्पोर्टेंट। जो अभी सही चीजें हो रही है, गलत चीजें हो रही है, वो कमेंट करने से पहले डेटा अपने पास दाखला ही नहीं है, तो द ट्रेंड्स ऑल्सो, इट मे बी अ परसेप्शन मैनेजमेंट, मिसकंसेप्शन, ये इधर जास्ती कर रहे हैं, वो इधर कम कर रहे हैं, दैट इज डेटा इज वन इंपॉर्टेंट थिंग। एंड पॉलिसी शुड मूव। आप बोल रहे हैं कि मेटर्नल हेल्थ के ऊपर ये हिस्टेरेक्टमी भाई चिपका दिए, तो क्या इट्स विमेन्स हेल्थ केयर। क्यों विमेन हेल्थ केयर में विमेन तो उसका पूरे लाइफ कोर्स में वो बीच में मेटर्निटी के रिस्क में भी वो अटक जाती है। एंड मेटर्निटी के दौरान जो उनको तकलीफें हुई है, लाइक डायबिटीज इन प्रेगनेंसी, हाइपरटेंसिव डिसऑर्डर्स इन प्रेगनेंसी, उसे एनसीडी में भी आजकल विमेन का कंट्रीब्यूशन काफी कुछ है, दैट मिलियंस ऑफ डायबिटीज एंड हाइपरटेंशन स्टार्टिंग फ्रॉम प्रेगनेंसी ऑनवर्ड्स, उनको भी हमने ऐसे ही पॉपुलेशन में छोड़ दिए हैं। एंड द लास्ट थिंग इज बियॉन्ड द प्रोडक्शन, रिप्रोडक्शन जो बोल रहे हैं, उसके अलावा भी उसके millions of women in India today have reached their perimenopause and menopausal age group। क्योंकि हम माँ के जाने जो बचा रहे हैं, वो तो बच के आगे उनकी जिंदगी चल रही है, और we have to keep a standardized policy in place, मैं मानती हूँ। लेकिन एटलीस्ट उसके बारे में अभी हम चर्चा कर रहे हैं, अनेक अनेक तरह एंगल से सोच विचार आ रही है। सबसे हम सहमत होंगे या नहीं होंगे वो दूसरी बात है, लेकिन विचारधारा तो शुरू हो गई है। दैट्स अ वेरी फर्स्ट क्रूशियल स्टेप इन एक्शन, एंड यू हैव क्लियरली एक्सप्रेस्ड what we call in common terms within the Foxy also and within the media also, the trust deficit, जो प्राइवेट और पब्लिक जो है कि एक दूसरे को दे आर नॉट ट्रस्टिंग ईच अदर। हमारे नहीं का गवर्नमेंट डॉक्टर्स की तरफ अलग सा होगा, गवर्नमेंट डॉक्टर्स के हमारे ऊपर नजर अलग से होगी। इट हैज टू कम ऑन अ कॉमन ग्राउंड, क्योंकि एक युवती या महिला कहीं पर भी जाए, ethical and justified options in treatment she must get with quality and dignity। उतना हमारा मेन मुद्दा है, जो whatever it takes for us to get there, we have to get it। So thank you for giving such important insights, क्योंकि the trust deficit has to bridge, policies have to expand to menopausal so that there is a proper networking of post-reproductive era of women, and the audit and data management should be in place sooner rather than later। So thank you for this very, very important points, Dr. Tarun, and we do hope that this discussion sets a stage for many more better things to come in future। Now let me go back to Kavita before I go to Shailendra ji। Kavita, now they're saying that okay, public private ये मतलब जिधर कम हो रहा है शायद, और many more women may need hysterectomies within the government space, we don't know who is being missed out। On the contrary, they're saying private में बहुत देर सारे हो रहे हैं whose uterus could have been saved। मतलब दोनों proportions can be still in a very confusing proportion। those who need it may not be getting it, those who don't need it may be getting too much। That is quite a, that's why we need the data and audit। मैं कविता जी से पूछना चाहती हूँ, she has done many hysterectomy camps। कहाँ से भाई आते हैं लोग, किधर से पकड़ के लाते हैं camps में, और क्यों where, what is missing and why they come at that time। what has been your experience? महिलाएं जानती भी है कि क्यों कैंप में आए और उनका क्या आगे होने वाला है, how much is the awareness, and is there any alternatives other than hysterectomies that you offer in your hysterectomy camp? आप थोड़ा, I know that strong background of yours, so I'm raising this question with you.
Thank you so much. Thank you so much. First, including into this panel, I'm really, really proud. The second point, most important, we have to go beyond the blame game, which we talk about कि private में ज़्यादा होता है, and definitely private में ज़्यादा होता है. I agree with thing. Third point is we divide these two things in a too broad manner. Number one, हम patient का perspective लें और gynecologist का perspective लें. The first perspective which I would like to talk about, the patient's perspective. Patient perspective हमारे सारे के सारे country में all the cultural problem, all the social backgrounds, all the social taboos, all going to the religious places, having a gadbad menses. So all the family wise, like doctor said, कि मैंने कहीं underline पढ़ा है कि बाल सफेद हुए तो यूट्रस पे sort of thought process in general public कि अब मेरा 45 साल हो गया है, so I don't want that uterus, which is really, really wrong. Which is wrong because of they are not properly, awareness is not there, they are not properly trained, they are not talked about the thing. The most important part, and then I come to the doctor's part. Number one thing is all over the India, the just passed a master's who has done PG in OBGYN, the easiest doing surgery is hysterectomy after the cesarean section. And they want to learn and they have that adrenaline secretion over there that I can do hysterectomy. But they have to be very, very sure to whom they are doing the hysterectomy. Are we doing that systemic approach is there? Are we using some guidelines or some things are there? Are we using some scoring to do these things? Are we having some second opinion doing this? And the third point is, what is the correct indication of it? Now, your question, which I loved it, that in so much camp, why we are having so much hysterectomies and how patients are coming and how the things are. See, there are two things. Sometimes patient wants, some experts should come to that place so that their surgery should be good. So all they are gathered and they are being indicated in hysterectomies, most of them, if the surgeon is good, he or she will find it out that whatever surgery I am doing the right indication. Number one. See, we are not saying that all those are doing with the wrong indication or some wrong intention. The most important point is the indication should be right. And why they come into the camps, they are the reasons, because they cannot reach to the thing. They want to do it in a some small, what they say, cost-effective packages, or they want to get it done in a camps because they don't want to rush to some big corporate hospitals, or they don't have the insurance or many more things, and they really want to do the surgeries. Now, it's the surgeon's choice that they should do it in a proper way and to train anyone with the right indication. A person like me who has done a number of surgeries, and if I'll say that if the patient comes after 5 consultations to me for getting the surgery done with me. So I like that person, that second opinion is very, very important. Another point is very, very important. And the students who are learning hysterectomies in a different camps, that's really another important thing. They should be very sure that it's the right indication. And the last point, which I love to talk about, in the Madhya Pradesh-like place, instead of OBGYN, surgeons used to do the hysterectomy. So how to put the lagam on those people? How you are going to stop these people? Hysterectomies are being done by, the uterus is a OBGYN's organ. So we will do it, but not the surgeons will do it. This is a very important point because they can do anything. They don't know the indication. They want, chalo, surgery karne. So this is important point. So these are the ethical concerns about you and what you said. We need a very real equality and dignity to our females with all the social aspects is very, very important.
Yeah, thank you so much, Kavita, because, being honest about the learning curve for the young gynecologists with adrenaline, and they're rushing to do anything, even with a 1 centimeter fibroid. This is a reality, and we feel, we ourselves feel so sad about it. And as I said, the disparity between what's done, what is desired is really, the gap needs to be shortened. Before I go to Bhaskar, the Shailendra ji, Chhattisgarh, are you happy that anyhow the maternal mortality is on the decline, excellent care is given during the time of delivery, लेकिन बाद में क्या, अगर ये महिला बाद में आती ही नहीं है सिस्टम में, तो फिर उसको कैसे आप ट्रैक रखते हैं अभी आज के दिन में गवर्नमेंट के तरह से छत्तीसगढ़, व्हाट इज द डेटा कैप्चर ऑन द पोस्ट रिप्रोडक्टिव, देयर बाय वी कैन गेट सम इनसाइट्स इनटू, अरे भाई इनके यूट्रस है भी या नहीं भी, अगर तकलीफ है तो गवर्नमेंट सेक्टर में उनको कुछ सहूलत नहीं मिल रही है, देन आर दे रनिंग टू द प्राइवेट सेक्टर, is what is happening. You can just guide us to, in the remote areas of Chhattisgarh there's also a possibility, दूर से आ रही है महिला, भास्कर पाल जैसा एक एक्सपर्ट आ गए हैं, वो 2 ही दिन रहने वाले हैं, तब तक उसको यूट्रस निकाल के वहां से भैया छुट्टी लेना है, क्योंकि वो बार बार नहीं आ सकती, और फैमिली वाले भी बोलते हैं कि एक बार में आप अपना काम खत्म करके निकलो यहाँ से। ऐसे कोई माहौल है या क्या है, व्हाट इज द ग्राउंड रियलिटी?
Thank you, Dr. Hema, and it's my privilege to talk in this panel. I am very glad to talk on this topic. जैसा आपने बोला कि महिला दूर से आती है, मैं मानता हूँ। जैसा डॉक्टर अर्चना मैडम ने भी बताया कि उनका एरिया रूरल एरिया है, सिमिलरली हमारा है, साथ ही साथ हमारा ट्राइबल एरिया भी ज़्यादा है। हम बस्तर की बात करें तो ट्राइबल एरिया पूरा ट्राइबल एरिया है, सरगुजा की बात करें तो वो भी ट्राइबल एरिया है। दूर से महिला आती है, नो डाउट। दूसरा, जैसा आपने बोला कि डिलीवरी के बाद किया, तो आपको मतलब मुझे बताते हुए बहुत खुशी हो रही है कि जो आशा प्रोग्राम पूरे इंडिया में लॉन्च हुआ, उसके पायनियर हम छत्तीसगढ़ थे। तो हमारे यहाँ आज भी मितानिन कार्यक्रम चल रहा है। 72,000 लगभग 72,000 मितानिन हमारे प्रदेश में कार्य कर रही है। तो हम प्रतिवर्ष क्या करते हैं, एट द स्टार्टिंग ऑफ ईयर, मतलब जो हमारा फाइनेंशियल ईयर होता है अप्रैल मई में, एक CNA बोलते हैं, कम्युनिटी नीड असेसमेंट, हम उसको कराते हैं इन मितानिन्स के द्वारा। उससे हमको पता चलता है कि कितने हमारे एलिजिबल कपल हैं, कितने मीन्स 15 to 49 ईयर एज ग्रुप में है, कितने की फैमिली कंप्लीट हो गई, कितने को फैमिली प्लानिंग की आवश्यकता है, कौन फैमिली प्लान कर रहा है, एंड वी डू ए ट्रैकिंग मैकेनिज्म थ्रू दिस ऑल मितानिन्स। जो आशा पूरे दिन इंडिया में आशा बोला जाता है, हमने उनको हमारा लोकल नाम दिया है मितानिन्स। तो वी ट्रैक द फीमेल फ्रॉम आशा मितानिन्स, और 72,000 बहुत बड़ी संख्या होती है। हम देखें तो हमारे जितने गांव हैं सारे गांव में है, साथ ही साथ हमने अर्बन एरिया में भी मितानिन को पोस्ट किया है, तो वहां से एक ट्रैकिंग मैकेनिज्म है। दूसरा, ग्रेजुअली आप देखेंगे कि मैटरनल मोर्टिलिटी रेशियो की आपने बात की, तो मुझे ये बताते हुए भी बहुत खुशी हो रही है कि अभी जो SRS आया है उसमें 23 पॉइंट के साथ हम सेकंड हाईएस्ट डिक्लाइन इन मैटरनल मोर्टिलिटी रेशियो है। तो डेफिनेटली ये ऐसा नहीं है कि मतलब अपने आप हुआ होगा, हमने सिस्टम स्ट्रेंथन किया है। रिमोट एरियाज में हमारे पब्लिक फैसिलिटीज स्ट्रेंथन हुए हैं। आप देखेंगे आज हमारे प्रदेश में 10 मेडिकल कॉलेजेस हो गए हैं, उसमें से 3-4 ही शहर के पास है, बाकी सब रिमोट एरिया में है। जैसे बस्तर में मेडिकल कॉलेज है, सरगुजा में मेडिकल कॉलेज है, कांकेर में मेडिकल कॉलेज है। तो हमने सिस्टम स्ट्रेंथन किया है। साथ ही साथ जैसा डॉक्टर तरुण जी ने बताया था कि रिपोर्टिंग मैकेनिज्म, वी आर वर्किंग एग्रेसिवली टू गेट द डाटा एंड एक्चुअल डाटा। जब भी हमको कोई पॉलिसी बनाना है, कोई सिस्टम को स्ट्रेंथन करना है, तो हमारे पास डाटा होना चाहिए, और डाटा सही डाटा होगा तभी हम उस पर एक्ट कर पाएंगे। फॉल्स डाटा, गलत डाटा पे एक्ट करना हमेशा कठिन होता है। तो हम डाटा पे भी काम कर रहे हैं। साथ ही साथ जो मल्टी स्टेक होल्डर्स हैं, कभी भी किसी सिस्टम को स्ट्रेंथन करना है तो हमें क्या जरूरी होता है, फीडबैक्स लेने होते हैं। हमको ग्राउंड रिलेटिव पता होनी चाहिए, तो हम मल्टीपल स्टेक होल्डर्स को हमारे साथ कोलैबोरेट करते हैं ताकि हम ग्राउंड रियलिटी को जान सकें, उनके चैलेंजेस को एड्रेस कर सकें। हम जैसे कैपिटल में बैठे हैं तो यहाँ के चैलेंजेस अलग हैं, पर रिमोट में हमारे जो बस्तर में है डिस्ट्रिक्ट्स, उसके चैलेंजेस अलग हैं, जो सरगुजा में डिस्ट्रिक्ट्स हैं उनके चैलेंजेस अलग हैं। तो वी आर टेकिंग द फीडबैक्स रेगुलरली। हमारे लिए 104 का मैकेनिज्म भी है जहाँ से हम फीडबैक लेते हैं। दूसरा, 1-to-1 हम मीटिंग्स करते हैं, रेगुलर बेसिस पे मीटिंग्स होती है। और तीसरा जो इम्पोर्टेंट है, एक अवेयरनेस है। अगर कोई मिथ्स है, सोशल कल्चर्स है, तो उनको ओवरकम करने के लिए हमको अवेयरनेस करना जरूरी है। अगर मेरे को कोई जानकारी होगी तभी मैं बता पाऊंगा कि मेरे साथ सही हो रहा है कि गलत हो रहा है। तो वी आर ऑल्सो वर्किंग ऑन दैट कि हम अवेयरनेस कैंपेन्स चलाते हैं। हमारे यहाँ IC बहुत रोबस्ट मैकेनिज्म है। सो वी आर गेटिंग द एक्चुअल डाटा, वी आर ट्राइंग टू गेट द एक्चुअल डाटा, वी आर वर्किंग ऑन अवेयरनेस कैंपेन्स एंड मितानिन सर और बैकबोन ऑफ हेल्थ सिस्टम। साथ ही साथ जो ANMs हैं और ग्राउंड लेवल पे मेडिकल ऑफिसर्स हैं, आप देखेंगे हमारे यहाँ 800 PSCs हैं, और हमने 2000 मेडिकल ऑफिसर्स हमारे स्टेट में लगभग पदस्थ कर रखे हैं। तो दे आर ऑल्सो डूइंग वेल इन द सिस्टम टू गेट द डाटा एंड एक्चुअल फिगर्स व्हाट वी वांट, एंड ऑन दैट वी आर वर्किंग for policy matters.
शैलेंद्र जी, एक ही सिर्फ वन फॉलो अप क्वेश्चन, अभी मिथानिन जो लेकर आती है मानो पोस्ट रिप्रोडक्टिव, मतलब उनके कोई मेंस्ट्रुअल प्रॉब्लम्स है या एसटीआई है, को जो कुछ भी है, और डॉक्टर कहते हैं कि नहीं नहीं आप यूट्रस मत निकालिए, विल प्रिजर्व द यूट्रस, लेकिन आपको हर साल यहाँ आना पड़ेगा, या 3 महीने या 6 महीने पे मैं बुला लेती हूँ तभी आपको आना पड़ेगा। वैसे उनको आने जाने की मतलब फ्रॉम रिमोट एरियाज उनको सहूलियत है, या दैट इज अ मेजर कंस्ट्रेंट फॉर एक्सेस? तो फैमिली वाले बोलते हैं नहीं हम बार बार नहीं आ सकते, अभी जो करना है आपको करो, क्या है
आप
उनका?
जैसा आप बोलेंगे ना, तो हमने मेडिकल ऑफिसर्स को ट्रेन किया अंडर एनसीडी प्रोग्राम। एक्चुअली उनको जो बार बार आना पड़ता है वो मेनली पैप स्मीयर के लिए आना पड़ता है। इफ सी इज हैविंग अ डिस्चार्ज और वाई डिस्चार्ज सी इज गेटिंग और 35+40 ईयर एज है, तो हम सस्पेक्ट करते हैं कि सीए सर्विक्स हो सकता है, तो डिस्चार्ज आ रहा है कि नहीं, और हम ईयरली फॉलोअप के लिए बोलते हैं। तो मैं मानता हूँ कि उनको दूर से आना कठिन होता है, तो ऐसा नहीं है कि हम सब महिलाओं को सेंटर में बुलाएं। We are decentralizing the program under NCD scheme. We are training the medical officers for doing the pap smear at local level, और वहां से सैंपल कलेक्ट करके वो हायर सेंटर में भिजवा देते हैं। मैं मानता हूं कि चैलेंज है कि महिलाओं को बार बार आना पड़ेगा, पर कम दूरी आना पड़ेगा, हम इसके लिए प्रयासरत हैं ताकि महिलाओं को समस्या कम हो।
नहीं नहीं शैलेंद्र जी, आपके हिसाब से मैं एक ही बोलूंगी, where there is a will there is a way, otherwise there are only excuses. आपके पास दृढ़ निश्चय है तो आप काफी कुछ अभी आगे निकल चुके हैं, which may become a role model for, and I hope it becomes a role model for the rest of the country who is just making one excuse or another. And this is a point very well taken. I really appreciate the humongous efforts and the way you have reached to one of the topmost positions in moving the needle further and at the fast track rate. So congratulations to you once again. Now the first round, last question to our leader and champion within our organization, Foxy, Dr. Bhaskar Pal, who has seen the best of both worlds, because he is also in a very important position as far as the AICC RCOG. He is at the helm of affairs, which is the Western world, the UK counterparts, what they do there. He's been trained there also, and he is on very high level posts within the country as well, and he has seen, the systematized way of doing things and the limitations and challenges that we may face in our country. My 3 points for Bhaskar are communications, which also I know that you've run many communication workshops, because you know the importance of communications, which is not really happening right, maybe because of the lack of expertise or lack of time. How important is communications in this whole exercise of preserving the uterus? How important is confidence and competence? Because you don't want to do a hysterectomy, you have 10 other options. But are everybody who is delivering care there have the expertise in those options which they can offer? Or is that a huge exercise of capacity building which we still need to do? And the third point for you is, Tarunji said PCP and DT Act. That, the law and the clutches and the constraints and the defensive type of a patient care in the already non-existing care, all these were, really huge problems. And now another wave like that coming in, akin to the PCP and DT Act, with the issue of hysterectomy. Where will we be in another 5 years from now if the mechanisms of the data collection, the audits, the justification, this, that, and the other have to be as, the comma and the full stops on the forms being taken to task that this is not filled in properly, or this, that, and that. So I want you to respond to these 3 main points. What is your vision and action points towards these?
Okay. Thank you, Hema. I have very strong views on this hysterectomy debate. And before I'll answer your 3 questions in the reverse order, but before that, I just want to set the context a bit. I think Tarunji has left because he had an emergency, but I actually disagree strongly with a lot of things that Tarunji has said. I think there's one big problem is what you mentioned is a trust deficit between the government and the private sector. And what we need to understand is that there is a big problem in this country at the present moment. Anything that happens well in the health sector, that happens because the government has done a great job. And maternity mortality has come down by 85%. So the government has done a great job. Nobody says doctors has done a great job. Whereas anything that there is a concern, like if the cesarean section rate goes up, or we think there are unnecessary hysterectomies going up, the entire burden is on the doctors. So anything bad that happens in the health sector is because of the doctors. Anything good that happens is because of the government. I think we need to have an alternative narrative there. And I think while the government consults Foxy in major decisions, I think this mistrust between the government and the private sector doesn't help anyone. And the government needs to understand is that the government's healthcare facilities is not optimum. It's difficult to be optimum because we are a very geographically diverse country. So the government also through the Ayushman Bharat has fallen back on the private sector. So we cannot manage that with a trust deficit. Now, in the hysterectomy issue, there are three narratives. One is the patient's narrative, one is the doctor's narrative, and one is also a third narrative. And the third narrative is, are people doing hysterectomy for money? Yes, some people must be doing it. But then in the society, in all professions, we have the black sheep. Now, Tarunji said that the Foxy should do something. Foxy has 39,000 plus members. And most members of Foxy are updated with the guidelines that we give. Unfortunately, more than half of gynecologists in this country are not Foxy members. And Foxy doesn't have a role like, say, Royal College has in England, that everybody who practices obs and gynae has to be a member of the Royal College, and they have to follow what the Royal College does. So people in pockets, they'll never come to listen to what Foxy is saying. So that is a deterrent. I do not know whether making a Foxy membership mandatory would help, but we have to discuss what we can do about that. The second issue is that a lot of places in India, surgeons are doing a hysterectomy, and then who is going to control that?
Yeah.
Now, I wouldn't recommend anything like a PCPNDT Act, because, doing a PCPNDT Act, yes, people do sex determinations, they should be punished, but there are people who are hauled up for very, very silly reasons. And by saying that you want to victimize people doing hysterectomies, people will not do necessary hysterectomies. Yeah. And you go with a gun that, why didn't you have an ultrasound? Why can't you show an ultrasound? It is like, there's a village, there are 100 men, and there is one terrorist, you kill 100 men to get rid of that one terrorist. That's not going to help anybody. Mm. Now, what would help is what the government has done. Now, the government has come out with this audit of hysterectomies, which is a brilliant form. And they have very carefully selected that which hysterectomies they will look into. Like in women who've had a hysterectomy before the age of 40, yeah. Women who've had their ovaries removed before the age of 35. They're insisting on a histopathology report. They're insisting on whether any alternative treatment has been given. Sure. Okay, so I think that is a very positive step forward. But what is wrong in the government guideline? What the alternative treatment? The government guideline says that if you have somebody with a precancerous lesion, you should offer them a colposcopy, CIN, etc. How many people in this country can do a colposcopy? If we have to send everybody to a colposcopy, there would be a 18-month waiting list like the NHS. In India, the government hospitals can boast of the patient. I have worked in the government sector for 8 years. Patients get down after a 4-hour bus journey, comes to the hospital with a prolapse, they get admitted, they get the surgery the next day, they go back after 7 days. Okay, and this is something with no waiting list. And this is amazing. Very few countries in the world can boast of a government healthcare where there is no waiting list. The government has said that any patient of prolapse, we should offer them a hysterosacropexy. How many people in this country can do a hysterosacropexy? That now brings me to answering Hema's 3 questions. Now, the PCPNDT, I think it's complete waste of time. It is the audit, we need to take it forward. And when we see that somebody is doing hysterectomies where something else could have been done, we need to get into that and see what happens. Now, why do doctors do hysterectomies? A majority of the reason is our postgraduate curriculum only teaches them to do an abdominal and a vaginal hysterectomy. It doesn't teach them to do anything else. It doesn't teach them to do a colposcopy. It doesn't teach them to alternative treatment for prolapse. So what will they go out and do? They will go out and do what they know. So every patient that comes to them, they need to fit into that patient into the either a normal delivery or a cesarean section or a DNC or a hysterectomy, because these are the 4 procedures they have learned to do. And that is a problem, that why many people do a hysterectomy. Great, because if they can do a hysterectomy safely rather than doing attempting a laparoscopic sacrohysteroscopy, which they are not trained to, is going to be a disaster. So we need a huge amount of competence and capacity building before we tell people that you have to do a CIN excision before you can do a hysterectomy, or you can do an alternative surgery for prolapse before you can do a hysterectomy. That's from the doctor's perspective. So this confidence capacity building has to go on simultaneously. The third problem in terms of communications is what the patient wants. If you look at all the data that has come out from different places, is that especially women who are daily wage workers, especially in women where the workplace doesn't allow them to work when they are menstruating, like the sugarcane fields in Bid, where the controversy broke out. And here, the thing that women want is a permanent solution. Number one, because they do not, it's not a question, as Shailandri said, that taking it to them, great. But can we say that the day you come for treatment or follow-up, you will get your daily wage? No, we cannot do that. So what needs, when we talk of communications, it is a three-pronged approach. Yes, we have to educate doctors that what are the alternatives that are available, and we have to provide them the training opportunities that they can provide them. The second part of communication is that we have to go back to, the government has to get to employers and say that if you do not want your women to work during their periods, you have to pay them salary and give them a menstruation leave, or you have to allow them to work. And the third is that a lot of women, because the daily wage earners who stay very far from a medical facility, they think that once I've completed my childbearing, my uterus is over. So I get rid of my uterus. I do not have to go back. And that again has to change. So we need to go to the society and need to tell them. Women who have a hysterectomy early, even if we preserve the ovaries, now we have good data to say that the future risk of cardiovascular diseases is much higher. So we need to educate. That is a part of communication. We have to educate the community. We have to educate the employers, and we have to educate the doctors, and at the same time provide them with the alternative training. The problem is that people who are trained to do different procedures, they do less hysterectomies. I don't do a lot of hysterectomies because I offer women, I am capable, I have the capacity to do it, but I am a minority. And that capacity building has to happen before we can say, what do I do? A human, a 35-year-old woman comes with an abnormal uterine bleeding. She cannot afford a Mirena. She doesn't want to, she cannot go on tranexamic acid. It is expensive. She cannot come back every 6 months to see how she is doing better. And then at the end of 5 years, end up in a hysterectomy. So she wants a hysterectomy, and the doctor is competent to deliver a hysterectomy. Now, what is wrong in that? If we want to change this is a much more complex issue which we have to do.
Yes. Yes, thank you so much, Bhaskar, because I knew that very strong and firm answers would be offered through you, because seriously, it is the lot of myths and misconceptions, not only in the community, but also within the medical fraternity and within the different health system that is existing. So which is, a huge barrier to the best way forward. And the competency building, way back 10 years ago, Hysterectomy Watch, there was a program where many activists were just snowballing as to why the alternatives are not being offered. And even those women who could have benefited from hysterectomy were denied, and they really got into so much trouble ever after in their life. So just bringing in a law, just trying to, implement it in the strongest way, which is a huge disadvantage for the defensive kind of practice that it would bring into our community. And finally, the women at the center would really struggle and suffer with the non-availability. So points very well taken. One last round of rapid fire, starting with Archana ji first. Archana ji, you're there? Dr. Archana Mishra?
Yes, ma'am.
See, you have a huge program on anemia management, but it is restricted to the gestational anemia management. It's a pregnancy anemia. You want to be sure that PPH deaths don't occur. You want to be sure that, the enough iron gets into the fetus, so the low birth weight, preterm, and outcomes are better. Post-delivery anemia is also being, to a large extent, Madhya Pradesh is the role model for demonstrating that parental iron, and then you discharge her with, and she has lots to benefit in the rest of her life. Have you extended your thought process of anemia care at every touch point? Because these women may soon land up with so much of bleeding and the anemic status. Only her bleeding is being quick fixed, but nobody is really seriously bothered about her anemia care. So is there any protocol change or policy change within your circles and spheres, within the control that you would have in your position to expand the anemia care across the life course, inclusive of perimenopausal, menopausal women?
Thank you, ma'am. We are taking care of women of reproductive age group, non-pregnant and non-lactating actually, and also beyond that, because with the iron distribution, that is ferrous sulfate salt, weekly distribution of IFA tablet is recommended by any Government of India and Anemia Mukt Bharat guidelines. And for this, we are incentivizing our ASHA workers. They are distributing one strip of 10 tablets every 3 months. They are going door to door because they are looking after 1,000 population, and in which if you look at eligible couple ratios are about 170 women are there. Beyond that, some may be there, but not too many. And the target of this age group is nearly 1 crore in our state, but we will not be able to reach to all women. So we have taken about 70% of our target. And like if you look at National Deworming Day, that is also important for combating anemia. It is being observed from in all the states as per Government of India's guidelines, and more focused on children 6 months to 19 years. But this time we have sent a proposal to our mission director that women should also be included in this. And on the 12th September, when it is observed, we all want our women to be given one tablet of albendazole during that campaign. And ma'am, just one more thing I would like to add to what Dr. Bhaskar said. We are very much thankful to our private partners, because without them, we would not have achieved the reduction of our MMR, which though we have not achieved our goal, but still we are on the right pace and reduction is there. If you look at cesarean sections, nearly 50% of the cases are being managed by our private sector doctors, and as a result of which in Ayushman Bharat, Madhya Pradesh has opened high-risk packages for complicated pregnancy for private hospitals also. And Madhya Pradesh is the only state who has done this, because we are not able to get doctors in government sector to that extent what we are wanting in sub-district level institutions. So we have opened these packages in private hospitals also. And also I must thank all my private partners for we are going for minimal invasive surgery in our district hospitals, in 12 district hospitals. So we are partnering with our private experts, like in Madhya Pradesh, we have Dr. Manisha Srivastava, Dr. Asha Bakshi, Dr. Archana Basir, who are doing minimal invasive surgery. So they will be our training institution, and they are recognized by FOXY also. And Kavita madam is here, who is our leader, and it is done under her guidance. So because ma'am, in government sector, if we want to do hysterectomy, we should have ultrasonography facility, histopathology facility. So all this is not up to the mark which is required. So we want to, like if we want to conserve uterus, we should have those gadgets, diagnostic gadgets, the minimal invasive setup. Like for the endometrial polyp, if she comes with intermenstrual bleeding, it can be managed by hysteroscopic removal. Some TO mass is there, and then indicated cases, minimal invasive surgery can be done. Our students will also learn, because now district hospitals are the centers, teaching centers also for DNB courses. So we need to partner with private sector and go ahead, because it is our state, our country, and we have to provide services.
Thank
we
you
have
so much. Thank you so very much, Archaji. It's always a pleasure to have you on our panels because you are the ones who will speak, with a very strong voice for collaborations and partnerships and acknowledge that each one in the wheel is important to deliver the care out there in whichever segment or sector. But every girl, every woman, leave no one behind, get our act together and move forward for better times to come. So thank you so much for that. In the last 1 minute of thank you. So in the last 1 minute of the closing, if each one of the other three panelists want to give one message on preserving the uterus, what would that be? Bhaskar, you go first.
Yeah, I think from Foxy is doing its bit. We are educating. We do the Save the Uterus program, which is headed by the Public Awareness Committee of Foxy, and we've done that. We have done over 100 programs up till now. But I think, as Archana ji said, I think we need to join the private sector and the government sector has to work hand in hand if we have to go forward and make things better. And I think making guidelines is great, but we need to plug the loopholes in the guideline. Yeah. And again, build capacity, educate. We'll have to think how the government goes ahead through its IEC to educate the community, and at the same time we'll take care of educating the doctors, how they can educate the community, bring everybody, every gynecologist under the fold of Foxy, whether so that can happen, and at the same time we can build the capacity.
Yeah, thanks, Bhaskar. This is yet again another positive note that we are also willing to do our bit to save the uterus and making things happen. Shailendra ji, one message to all of us.
One message में मैडम हम ऐसा कर सकते हैं कि overcome the myths, because there are lots of myths in the community and field level. To overcome the social factors, we have to overcome the myths. Second is the capacity building of the service provider down the line, so that this when female has to less come to the higher centers or center level. And last one is the awareness campaigns. What we can do is awareness campaign. And last point I want to tell you is this collaboration with multi stakeholders to get the real data and factual challenges facing in the field.
That the fact that everybody is willing and wanting to do is really, we are ending on a high note. Last word from our future leader, Dr. Kavita.
Thank you so much. I think the most important point is we need to have the medical schools and the residency programs should have the good and better training programs. They should be really taught about not only the hysterectomy as you told about, that we need to train them how to save the uterus at that time, number one thing. Number two, we need a special courses for them all over the time, as I'm talking about for our own fraternity, and the training simulations and the mentorship, like Bhaskar said about it. And the other part which I feel like we as a doctors, we should talk to the awareness programs for the general public. They should know about their own health. They should know about their reproductive rights. They know about the reproductive choices. They should know about the mental health, the maternal health, the emotional, and all blame game should not be there. There should be a right statistics, right instructions to each and everyone, why we are blaming each other. Otherwise, this will also become a bad law, bad thing in the future. Thank you so much.
Thank you. Thank you so very much to Dr. Archana Mishra, Dr. Shailendra Agarwal, Dr. Tarunji, who had to leave on an emergency, Dr. Kavita Bapat, and Dr. Bhaskar Paul. Thanks to IHW Council and Bayer for bringing us together on this brilliant discussion forum for us to think better and do better. And we do promise that together we can and we will raise the bar both for the right kind of demands and the strongest quality-driven ethical supplies from our end too. Namaskar. Thank you very much again.
Thank you, Dr. Hema, for so expertly leading the session. We thank you. We thank Dr. Bhaskar Pal, Dr. Kavita Bapat, Dr. Shailendra Agrawal, Dr. Archana Mishra, and Dr. Tarun Chaudhary for taking out time from the busy schedule, imparting us with wealth of knowledge and information for this session. Thank you so much. With this, I request the panelists for the next session to kindly switch on their video as we are starting with the second session now, and keep your mics off. So this session is on the topic of patient perspectives, wherein we would be talking about transforming women's health ecosystem with a focus on hysterectomies. This is an initiative by IHW Council along with Foxy and Bayer. I welcome everybody for this session. I welcome Dr. Kiran Pandey, who is President of Medical Education Committee of Foxy. Ma'am, thank you so much. Welcome to the show. I welcome Dr. Jyotsna Suri, who is Consultant and Professor Obstetrics and Gynecologist for Gynae Department, VMMC and Safdarjung Hospital in Delhi. Ma'am, thank you so much. We welcome you to the show. We welcome Dr. Ashish Gavre, who is Country Medical Director for Bayer Pharmaceuticals India. Sir, we welcome you to the show. We welcome Dr. Madhu Gupta, who is Professor of Community Medicine, Department of Community Medicine and School of Public Health at PG IIMer, Chandigarh. Ma'am, very welcome to the show. We welcome Dr. Nighat Firdaus, who is an obstetrician and gynecologist herself and has experienced hysterectomy in her life. So she would be giving us the patient perspectives. Ma'am, thank you so much. We welcome Dr. Anjali Sawant, who is a PhD in English literature and has also experienced hysterectomy in her life. So she would also be providing us with the perspective. We welcome Ms. Raju Bai Meena, who is resident of Chiklod district, Parpadganj, and has experienced hysterectomy in her life. So we welcome her as well. We have Vijay ji with her, who would be helping us if there is any language barriers. This show is expertly being moderated by Dr. Ratna Devi. Ma'am, we welcome you to the show. Dr. Ratna is Director for Patient Academy for Innovation and Research and Chairwoman of ISPOR Patient Council. With this, we welcome everybody to the show, and now I hand over this session to Dr. Ratna. Ma'am, over to you.
Thank you, Dr. Asavri. And good afternoon to all the panelists. Welcome to the second session for the day. Our topic today is transforming women's health ecosystem with a focus on hysterectomies. And as Dr. Asavri pointed out, we will be listening to the lived experience of patients and understanding from them what kind of gaps exist in the system and whether these gaps can be addressed by listening to the insights that come from them. We have 7 panelists for this session and we have 1 hour. So I propose that we have 1 to 2 questions per panelist, and I will start with the lived experience first so that we hear from them, and then take it forward so that we can have a rounded discussion. After hearing the lived experience, what can the other experts from the field bring forth to the discussion? So without much ado, I would like to start with our first panelist, Dr. Firdaus. And ma'am, my question to you is, you are a trained obstetrician and a gynecologist yourself, and you also have an experience of undergoing an hysterectomy. So what were the circumstances that led you to this decision, and how were you supported in this decision? I know that you would understand the pros and cons, but coming from you as an expert, it would be great insights. So over to you, ma'am. Ma'am, please unmute yourself. We are unable to hear you. I think we've lost her. So maybe by the time she joins, we can go to our next panelist, Dr. Anjali Sarabhai. And I have the same question for her. As a person who is educated, emancipated, and understands the pros and cons of a surgery like hysterectomy, what drove you to that decision? How did you arrive at that decision? And what were the circumstances that led you to that kind of a decision?
Thank you for your question and inviting me to this list of all doctors and panelists. And I hope you all are getting my voice here.
Yes, we can hear you clear.
Okay. Yes, because now I had my hysterectomy 18 years back. Now, since my puberty, I got very heavy menstrual cycles that time, and the period lasts for, I think, more than 10 to 15 days. And that time during my school, when I was in high school, that time I also suffered a heavy loss, and with that I got highly anemic. My hemoglobin reduced a lot, and so my parents were much worried about me to what to do, because at that time not much of the therapies were there during that period. And after that, I went to Jaipur because of the laser treatment that was given only to bigger cities, not in my hometown in Bhopal that was available. So I went to Jaipur. My parents took me there to my relative's place there. Then for 2 to 3 months, I stayed there. My therapies were done there. And from that, I got the relief, which lasts only for a few years, 1.5 years, not more than that. Then after that, again, my cycle started after marriage. I had a problem. After marriage, I had I have 2 daughters, and then after the birth of my second daughter, again the same menstrual cycle started, and I took many therapies and everything whatever is possible for me, to my proper medication and everything. But then nothing was effective for me. Then I opted for this hysterectomy as suggested by my gynecologist and all the opinions of the doctors. They said because nothing was more available that time other than hysterectomy. So this was my experience.
Thank you, Dr. Anjali. Were you also advised on the pros and cons of such a surgery?
Yes, I was advised, but nothing was more better for me during that time because my condition was deteriorating day by day. I went for many therapies. I have 2 daughters, both were born cesarean. After the birth of my second daughter, then I had to undergo this. Yes.
Thank you. Thank you so much for sharing those experience with us. I will now move on to Raju Bai, and if Vijay ji can assist her to switch on the video as well as the audio. राजू भाई नमस्कार, मेरा नाम रत्ना है. आपने ज्वाइन किया, थैंक यू सो मच. इस पैनल में आप साथ दे रही हैं हमारी. आपने अपना जो गर्भाशय है या जो ये है हिस्टेरेक्टोमी आपने करवाई है, इसके पीछे क्या कारण था? आपको किसने सलाह दिया इसके लिए, और आप इस डिसीजन पे कैसे पहुंची? हमें सुनाई नहीं दे रहा है राजू भाई. विजय भाई आप प्लीज अनम्यूट करिए.
कारण तो ये है कि महीना में 2 बार लाल पानी जाता, कने का बेटा 2 बार जाता, कने का बेटा तो 1 बार जाता, कने का तो महीना भी जाता, फिर बाद भी जाता, लेकिन तो तगली आ तो 2-3 बार 2-3 साल टाइम न रो मारती तो थोड़ी ज्यादा तकलीफ हुआ लगी, तो वजन दूसरी हॉस्पिटल खरे खड़ी दवाई खरा डॉक्टर थी खरा गोलियां कटा ने दी थी इन्हें, जैसे बड़ी सादड़ी गया वहाँ जो बड़े हॉस्पिटल है यूं किसी ने किया कि बटे जाओ यूं मैं मन थी का हॉस्पिटल बड़ी सादड़ी से बटे डॉक्टर साहब ने फसे ना सोनोग्राफी कराई जे ने क्यों के थाने ठेली रे सूजन आएगी, तो सूजन आएगी क्यों तो माने वहाँ तकलीफ पड़ रही थी कि वहाँ वो तो लाल पानी तो बंद हुआ ने सालता दरिया पड़े, डॉक्टर ने बोला कि यो तो बस सतानी की सूजन आएगी है तो ऑपरेशन हुए थाने तो कई करना पड़ेगा. तुम्हारा घर वाला बोलियो कि नहीं तो वंसावना का 12 में लाइयो तो वंसावनी पड़े, तुम्हारे लुगाई जब मर जाए तो कई करो मो तो थाने ऑपरेशन करना पड़े, तो अच्छा ऑपरेशन ये ठेली निकाली. 8 दिन माँ बटे बढ़ती रिया, तो 8 दिन रुकिया माँ बटे राकिया माए सब सेवा साकरी गणेश की थी, बटे मैडम थी, कंप्यूटर था सब. बाद में मैं गोलियां दवाई दीदी मायो दीदी सब सरकारी से કીધું પૈયા હૈયા કઈ પૈસો હૈજો કઈ નહીં ઘણી તકલીફ માં ઓપરેશન કરાયો યો થેલી निकाली थी थैली में दुख आई रहा था तो थैली निकाल दी
हाँ, तो राजू भाई, आप कह रही हैं कि आपके थैली में सूजन आ गया था, तो ये तकलीफ आपको कितने साल तक थी और कितने साल बाद आपने ये ऑपरेशन करवाई?
तो हल्का हल्का चलता रहता कई नहीं साथ धकेगा यूं तो
17 साल थी।
हाँ साल तो वो 3 साल होगा
3 साल, अच्छा।
हाँ।
और अभी ऑपरेशन करवा के कितने साल हो गए?
अभी करवाया भाई हमने 10 तारीख ये 10 तारीख
अब
मई
आप बिल्कुल ठीक है?
10 मई को हुआ था। सभी को नमस्कार।
अब तो ठीक हो बढ़िया बात
ठीक है। So maybe I can go back to Dr. Firdaus if she is available. And Dr. Firdaus, if you could share your experience with us on how oh, she's still connecting to audio. So I think we have a problem there. So I will move on to our next panelist, Dr. Kiran Pandey. And she is president from the Medical Education Committee of FOXI. So, ma'am, my question to you is, we were planning to hear 3 patient stories and learn from them their experience of how they came to a decision to undergo hysterectomy. And we often talk about patient-centered care, where patient is an integral part of the decision-making. So my question to you is, how can a patient-centered approach effectively address the issues that have been shared by our 2 lived experience panelists who have joined and shared their story with us? And how can we elevate the overall quality of life of women who plan to undergo hysterectomy or who have already undergone hysterectomy?
Thank you, Dr. Ratna. I hope I'm audible properly.
Yes, ma'am.
Yeah. So at the outset, I'm very thankful to IHW Council who has taken this initiative. And this is the most important, I think, session, because the women who have undergone hysterectomy themselves are participating. So this becomes more practical and already a patient-centric approach. As far as you said, we had 2 persons. I could make out details of Dr. Anjali, but to very clearly, I could make out the Dr. Rajul Devi's very clear perspective. So maybe I'll try to do justice with it. Now, as far as Dr. Anjali Sarvai's narrative is, she actually suffered since very beginning, probably almost since menarche, as she said, with the bleeding. And he has been taking, she's tried a lot. Not that it was neglected. He tried whatever possible therapies were there at that time. In fact, before the marriage also she was having, and after the marriage and she had the 2 children, again she was suffering with that. She tried a lot to save the uterus, but could not. So sometimes we do actually face such type of situations. I'm definitely sure that she must have got all the investigations done, that what were the reason, and as she was saying, her condition kept on deteriorating. I think so that means hemoglobin must have been going down, and she must be feeling weak, or day-to-day activity must have been difficult for her to do the day-to-day activity. This is what is implemented. If Dr. Anjali can correct me if there is anything which not according to her statement. So here comes the point. First thing is, like these days the debates are going on the hysterectomy, when should it be done, the audit and the age. I know, I think doctors have been teaching this since very beginning, that the basically up to the perimenopausal age group, there might be to keep coming into the, so clear cut there on which we have to discuss, talk with the patient, and then take a decision. But sometimes, as in this case, it seems this has become must for her to undergo hysterectomy, probably before the right age, and there might have been some problem, although he has not told any post-operative complications or anything. So this was the basic thing. Now, basically, what you want to know, or I think what public should want to know is that whenever we are taking a decision, this is one thing very important. Is it really must for her to do, or we too have certain alternatives? And those alternatives should always be tried, specifically if she's of a younger age group and she's not, there's no doubt of like some neoplastic problem or very complicated. But there's one very good, but clear-cut indication. If patient is becoming anemic repeatedly because of the heavy menstrual bleeding, if it is affecting her day-to-day life and she's not being corrected by alternative therapy, then definitely there comes a role of hysterectomy, which seems quite justified. Now she also, I think, said, if I heard correctly, that it was discussed the after effects and those effects. That is very important. Whenever I tell you a situation, I am also practicing doctor, medical college. So what happens? There are sometimes the women do come with this mindset that they have to get some problem, little bit of problem for 1 or 2 months or 3 months, or maximum 6 months, and they take a decision on their own. That on the husband also, the family takes the decision that the best easier method is to get this organ removed instead of trying alternatives. But I would say personally, there are certain practical issues also. Although I do not agree with this, we do have to counsel them. We do have to tell them that if the hysterectomy will be done, obviously, once the uterus goes, ovarian function also gradually decreases. So she will have actual menopause before the time. And that will result into, like, she will succumb to bone health will be affected, the cardiac health will be affected, the skin will be affected, all the systems of the body will be affected. So they should be specifically bone health and cardiac health, and these are very important. So it has to be told, skin is one, is okay. So these things should be explained definitely, specifically in young age, and we do also have to, as you were saying, how we can elevate their research. So if we have to encourage them to discuss. What I personally do in my practice, whenever the patient comes of young age with these problems and they want hysterectomy, so in first visit, I just tell them, see, this first thing we have to see, is it really required? Is it not required? We have to reach to a justification. If supposing justification is there by multiple factors are there, then we have to tell them if this can happen, number one. And what is the process of hysterectomy? How she will be investigated? She will be admitted. These many days she has to remain admitted. And in medical college, there is not much of a expenditure, but in private, there will be financial burden also. And the most important is post-operatively, she has to be under follow-up of with the doctor and keep on communicating these problems, because this is the sudden. The menopause comes to every woman, but the changes are gradual and time to time. But in surgical menopause, there's a sudden loss of hormones almost. And specifically if the ovary has been removed. Many a times, you must have also come across, if you are a medical doctor, that surgeons, when they are doing, they don't, like even the patient's family wants to sab ek bar mein remove kar do. And surgeons also, they remove the ovary also. But which is the most important organ, at least if the uterus has been removed and the ovaries have not been removed, they will be, function will be decreased, but at least it will take 3-4 years, 5 years. So it will be a gradual menopause. But if suppose the ovaries has been removed, it will be a surgical menopause and immediate. Then the post-menopausal symptoms will be there. And by chance or with the grace of God, I'm menopausal specialist also. So my concern always remains with the menopausal problems. And there we have to take the patient into confidence. If you are supposing going under this because of their need, then this all has to be there. If you might need the charting, if you might need counseling for bone health, for yoga, for exercise, for diet, and specifically the cognitive problems, that all that anxiety and the ghabrat and
Yes.
things like that. So they have to be tackled, they have to be taken care. And of course, we start with the minor things like lifestyle changes. But sometimes when the lifestyle changes are not working, then we might even have to go for HRT. Then you have to explain it that this is for a short time and this is need based, and gradually you have to improve it finally by the lifestyle. And we are there with you. Every problem we'll together communicate. So developing a trust of the patient and encouraging her to come out with her problems, neurogenital problems, birth problems for the lady, if they don't even share. So we have to ask leading questions.
Thank you.
There's lot we can discuss.
Yeah, I'm sure. And you raised some very relevant points, especially about counseling pre and post surgery, and counseling being a lifelong kind of offer, especially for surgical menopause, because there will be sudden changes. The myths and misconceptions where patients come with predetermined notions on why the uterus has to be removed. And also, what kind of therapies to offer if it is a surgical menopause, and whether counseling has been given for those therapies. So thank you so much for throwing light on those areas. And as you said correctly, each woman would be different, and therefore the dialogue that the gynecologist has with the patient has to be customized accordingly, depending upon what stage of life they come in and what kind of therapies are being offered to her. So thank you so much. And that leads me very nicely to our next panelist, Dr. Madhu Gupta, who is the Professor, Community Medicine, Department of Community Medicine and School of Public Health, Postgraduate Institute of Medical Research, Chandigarh. So Dr. Gupta, just as a follow-up to what Dr. Pandey said, there are lots of myths and misconceptions out there where women feel that if there is abnormal bleeding or if it is interfering with their day-to-day activities, because there are a lot of social stigmas as well that are attached to it, or religious activities cannot be performed, then it is best to remove the uterus. So what can we do, especially in terms of community-based interventions and awareness campaigns, to raise awareness amongst women on the best options that are available for treatment, and what to do when they are searching for information? Especially these days, young women are searching everywhere. So what can we do to get that information to those people? Ma'am, we are unable to hear you. Maybe you could disconnect your headphones and speak. I think we are unable to hear you. No.
Am I audible?
Yes, very much. Please.
Hello, am I audible now?
Yes, we can hear you now, ma'am. Please go ahead.
So thank you so much, Dr. Ratna Devi, and I'm thankful to the organizers for actually keeping a session on this very important topic. Yes, definitely. In the community, there are, we can generate awareness in the many platforms which are already there. And the health system already have done it for institutional deliveries. If you remember, the percentage was around 30%, and now it has gone to 90%. And this we could achieve by this accredited social health activist who went house to house at the village level, and she did behavior change communication with the women in that household. So if we can link up this issue with the grassroots level worker, frontline worker who is part of the community, Ashas, so we can deliver this message at the household level. So at the grassroots level, one is Asha. Then second, we have platforms like where women meet actually with each other. Like we have self-help groups, Mahila Mandal groups, and Anganwadis also, although those are slightly younger age group women, but we have seen that women in 28 years and 32 years also have to undergo hysterectomy. So these women groups which are already there, these platforms already there, we can utilize these platforms for raising the awareness. This is at the grassroots level. Then second, if you then there are family members also. So it is, I mean, we have to talk to the family members also, that it is not necessarily that every time to get rid of the problem that hysterectomy is the only choice. So we have to make them aware as well. Then coming to the service provider level. So the first point of contact is the A&M. So A&M has to be made aware in some of guidelines, some training session, sensitization one day. He has to be made aware because that is the first contact in the public health system. Then comes the medical officer at the primary health centers, community health centers, and district hospitals. And they, the doctors, MBBS doctors are mostly there. So they also need to be made aware of the alternate methods of treating these problems, where like heavy menstrual bleeding, as already the earlier speakers have shared. Example like vaginal discharge, which can be easily treated with the antibiotics and syndromic management or whatever. So the other options it should be known to them, and especially if there is a heavy menstrual bleeding, like we have levonorgestrel, intrauterine system. So that is very, very useful, and I can share my experience with that. I had this issue of very heavy bleeding, and adenomyosis was the problem, and I've been inserted this. I'm 49 years old, and I'm perfectly all right after that, and my bleeding used to last for 10 to 15 days. It used to be very heavy. I used to wear diapers for the children because it used to be that heavy, and now it is almost normal, and it subsides in 7 days or so. So it is very, very effective, and this is a good platform where we are sharing our own experiences also. So, and I think lot needs to be done to make awareness among the service providers also, not only community. So Ministry of Health and Family Welfare, because they are the ones through which the health programs are being implemented at the community level. So they have last year taken out the guidelines, and Foxy is aware of that. So in 2022, they have come out with their guidelines wherein what all needs to be done at the grassroots level, at the sub-center level, at the primary health center level, at the CSC level. So they have clearly listed out what are the alternate treatment options available. The woman comes with the conditions wherein hysterectomy is required. So those should be tried, especially uterine prolapse, those should be tried first. And then if, as Dr. Pandey has already mentioned, if need be, then we can think of conducting hysterectomies. So this is I wanted to share at the community level, and this has to be implemented. One good thing is that because I work in the community, I work in a community health center. So we need to report the number of hysterectomies done in a month in the monthly report. It was not there earlier in the program. This was started last year only after that petition, wherein most of the hysterectomies were done under the government-sponsored scheme, insurance scheme, and the women were mostly from the other backward or marginalized communities. So after that, they have to report to all the hysterectomies, what were the indications, why it was done. So I think that kind of monitoring is also will help in basically in rationalizing the hysterectomies. So they have to report.
Thank you, ma'am. You raised two very important points. One is, of course, the guidelines that need to be followed by the healthcare practitioners and the trainings for the frontline workers in terms of messaging, as well as the reporting mechanisms. So my follow-up question to you is, these guidelines and these reportings are mandated just for the public sector or for the private sector as well? And if it is not mandated for the private sector, then how are we going to capture information for hysterectomies that are happening outside of the public sector?
Currently, as of now, as in the guidelines, it is actually restricted for public only. But there is routes, we should also reach out to the public, to the private sector also, and maybe it can be done in collaboration where the government and private organization should come together, and they should make it mandatory to report the hysterectomies and the need for hysterectomies.
Thank you, ma'am. Thank you. That is very insightful. And
Excuse me, am I audible? I'm Dr. Firdaus.
Yes, ma'am, you are audible. Please go ahead.
I'm sorry, I was at the clinic and there was some fault with the the Wi-Fi and something. So
No problem,
can I
ma'am.
come in? Can I
Yes,
come in
please.
or you?
Please go ahead.
Good afternoon, everybody.
Good afternoon.
Today I've been asked to deliberate as a patient.
Yes.
But my 45 years of experience, I still must have done the least number of hysterectomies. Not that in the private sector, in the government sector, being the head of department, as so rush of patients, I have done many. But I, before going to my history, I would say that doing unnecessary hysterectomy should be made a punishable act. It is a crime. It should be put in, letter and spirit that it is a crime and it should be punishable. Because people think that it is an organ just to produce children, and then it becomes vestigial. So I have personally, I don't boast about it, but I have personally been able to convince so many patients that not to go for hysterectomy, and their outcome has been very good. So the message would be that there is no compromise on removing the uterus unless it is incapacitating the daily routine life of a patient. So harm versus benefit has to be there. If it is crippling her, if it is taking a toll of her life, it is threatening to her, yes, of course, you have no alternative but to remove the uterus. But if it is just for minor, indication like menorrhagia, hemoglobin goes from 9 to 8, and then, okay, I have completed my family, I don't want more children, it's a hassle every time taking medicine. No, try to aware the patient. I think awareness comes first. My belief is that awareness is first, because I have been able to curb lot of hysterectomies, and then at the end of the day, the people are thankful also. But so I say that we have to aware the doctors also, and we have to aware the, of course, the patient. That is our moral duty to do. As far as my history, if you're interested in that, I can, just give you my history, why I got a hysterectomy done, if you are really interested in that.
Please, ma'am, please go ahead.
Yeah. Actually, I was in my 30s, and I had no idea of not to have I have two male boys through cesarean, and there was no, I never thought that I would not have the third one. I was desperately waiting for a daughter. But I don't know what happened. I suddenly started with menorrhagia, and I started bleeding profusely to the extent I took hemostats and other things for 1 or 2 months. And then I just went for an ultrasound. And in the ultrasound, my sonologist in the hospital with the other people, I was doing senior residency those days, my colleagues told me, मैडम इतना छोटा है, जब तक आप मेनोपॉज में जाओगी तब ये बड़ा हो जाएगा ये फाइब्रॉइड. But unfortunately, and they said, get up, मैडम ये आप 30 साल के बाद बड़ा होगा, तब तक आप मेनोपॉज में गए होंगे. So everybody assured me, but it was unfortunate. It was, I don't know what happened. It started growing rapidly, and those days diagnostic DNC was a choice. Diagnostic DNC was done. I was taking hormones for some time, so it revealed pill effect. But within 1 month, I deteriorated so much that my hemoglobin went to 5. I bled profusely, and you will not believe that my mother-in-law and other, they thought she has aborted. She's bleeding so much, she has aborted, and she's not revealing it. So I was taken to the hospital, and my head of department those days, unfortunately, all residents were on strike. She said, you have to choose between your life and yourself. So it was I had to transfuse 2 pints of blood. blood hysterectomy was done, the ovaries were preserved. I think that time my head of department, because the rapidity of growth and the symptoms was alarming. So there was no choice but to go for a hysterectomy. And those days there were not so many modalities of treatment, LNGs and other things, and lasers. It was, I think, it is now 28 years back, although it was in a government setup. So I can say in my case that it was not a non-genuine one. It was a genuine, although the age was very young. I could still have lived with the uterus another 15 years, but because my hemoglobin was dropping, I had to be infused blood, and it had started enlarging at a very rapid rate. So it was, I think it was genuinely indicated. But as far as others, I say that hysterectomy should not at all be a rule, because in spite of preserving my ovaries, I think after one is that I was deprived of having more children. That's one, because the second child was just 3 years old, or I think 3+or 4. So that was not the age of removing the uterus. You never know what happens in the future. But because I was incapacitated, so it had to be done. Then, as far as the ovaries are preserved, yes, I think they benefited me. I did not get the surgical menopause. I did not get those the maddening symptoms, vasomotor instability. But retrospectively, when I think, my GI system and my sleep disturbance started right from that day. So I think I just go and I try to go into the details, what happened, but I right from that time, my GIT and my sleep have been really disturbed, but now one gets used to it. So there are definitely effects of hysterectomy. No, one is the losing and not producing children. That is a different issue. But otherwise, and of course, vasomotor instability that comes, surgical menopause is worse. But I have been lucky that my ovaries are preserved, and slowly. But then when I would really get my real menopause, I did not feel that much, to be frank. Then, of course, these bone changes and other things, those otherwise also happen with age. So in my case, I think it was a genuine. And why it happened and why, I think something to do with the menarche. My menarche was very early. It was just 9+. It was a precocious sort of a thing. And I used to be very obese. So when I relate those things, now being a gynecologist in the field for so many years and teaching for 40 years, I think there was an association between. Because why it happened all of a sudden, and when you go into the retrospective history, so some hormonal imbalance was there, and which led finally to I can say I don't call it a disaster for me. It was a disaster for me. And not 35 years you lose your uterus, and children 5 and 3 years of age. So my advice, my message would be, never ever venture on hysterectomies. Try to preserve the uterus as long as you can, because it's not only if we remove uterus in young patients, young females, God forbid they lose their babies. God forbid they lose their husbands. So what do? We have IVFs now, we have IUIs now, we have so many things now. So, I mean, God forbid if she loses children, she still has hope she can go for an IVF at 40 years of age also. At 45 years of age also. She can go for artificial reproductive techniques. God forbid she loses her husband and she gets married again. So nobody will, if she doesn't have a uterus, then there are, stigmas and no, it shouldn't be done. It will not marry her. So many things, socially, morally, and of course, ethically and medically, uterus should be preserved as long as you can.
Thank you, ma'am. Thank you. That was very well said, especially about the social aspects of women who want to remarry or to have children again. And just sharing from the experience of Dr. Gupta as well as yourself, I was lucky enough to have a doctor who advised me against a hysterectomy. So I actually was going to a private sector doctor who advised me for a hysterectomy. And because I belong to the defense services, The doctors at R&R told me, no, do not do that. We can manage this medically. And it worked very well for me. So I think a lot depends on how the doctors counsel the patients and convince them. I was so desperate. I didn't want the uterus anymore because I was in such a sorry state. I couldn't travel anywhere. I couldn't attend conferences because I was scared of sitting for 6 to 8 hours. So all these things play on your mind. And even as educated people, sometimes you're strongly convinced that you have to get rid of the uterus.
Yeah. Sorry for interruption. One of my colleagues, when I underwent this thing, it was really, it was the whole hospital was shattered when I went for hysterectomy, because a young female going for the whole, and then everybody started pouring in my home. Dr. Nigat could milne jayenge, and one of the person, don't have to name her. She was very fond of doing hysterectomies at 28 years of age, 29 years. She told me, "Why are you so gloomy? It was a vestigial organ. You already have 2 children." And I really felt like, throwing her out of my house. I told her, it's not a vestigial organ. Don't tell me, because I am unfortunate. I had to face it. I had no way out. But I don't say it is a vestigial organ. Your body needs the uterus. Why should you have? And then everybody was saying, don't get offended. She's like that. And because she used to be, go for early hysterectomy, because her funda was, well, children produce, nothing doing, she's getting menorrhagia, why should we take the hassle? Take out the uterus. So
Thank you.
and of course the surgeons, with due apology, surgeons are going too much into the hysterectomies and they don't know the consequences, what's going to happen afterwards. So again, I would like to say, preserve the uterus till the last.
Thank you, ma'am. Thank you. Very well said. And with that, I would like to move on to Dr. Jyotsna Suri, Consultant and Professor of Obstetrics and Gynecology, VMMC and Safdarjung Hospital, Delhi. Ma'am, we have heard such powerful, compelling stories, and we know that patients present with this predetermined notion that it is causing too much trouble and we have to get rid of it. And doctors, as Dr. Firdaus said, sometimes find the easy way out, because if you do a medical management, it's a long process where you have to keep answering the patients, their questions around their discomfort and a lot of other issues around heavy menstrual bleeding. So in your opinion, and as a seasoned gynecologist, how would you, define shared decision making where the patient and the treating doctor are convinced that this is the best option that is available for the patient, and what can be put into place as a process for this shared decision making?
Yeah, thank you, Dr. Ratna. So, first of all, I would like to thank the organizers for organizing and inviting me here this afternoon for this session. So, taking off from where the other panelists have been talking and about the shared decision. In my practice, I have seen, a wide variety of patients who belong to both extremes. One who are so passionate to retain their uterus, even if there is, all the indication for hysterectomy, and the other who are young and with whom, we really have to work very hard to convince them that alternative methods are available for them and they would do much better without hysterectomy. But they have those preset notions, which, maybe from the family or from the society where they live. It's very common in some of the states from where they come. And, I recollect about a young patient who was just about, say, 31, 32 years old. She came with prolapse. And I myself was, maybe another 10, 15, maybe 20 years younger than what I am today. And we had planned her for a Manchester surgery. And I remember we were, very happy that we have taken this decision for this young woman. But then suddenly, when the day before the surgery, the husband appeared and he got very, upset with us. And he said, why are you doing this surgery for my wife? Because previously husband was not in Delhi, he was in the village, and the woman was convinced. We had done the counseling. So he said that, why should you retain the uterus? ये तो बिल्कुल ठीक नहीं है, आप पूरा set निकाल दो. So I was like astounded. I said, what do you mean पूरा set? He said, "Sab kuch nikal do. We don't want. We have had 3 children already, and this is not going to work for us. क्योंकि फिर दोबारा हो जाएगा prolapse. And where I am a daily wage person, I can't keep taking leave and coming to Delhi for treatment. So I'm not convinced. So let me, I mean, as a younger person, it was very difficult for me to convince the husband. And we did all the counseling to him and explained him everything about what could be, the problems with his wife. But he was not convinced. And the woman also did not give consent. And finally, we had to do the vaginal hysterectomy for a patient who was prepared very well and who was fit for Manchester. And, this is the sad part about, this particular scenario. I think they have these notions, cancer ban jayega, हम बच्चेदानी नहीं निकालेंगे तो हमारी को कुछ ये प्रॉब्लम्स हो जाएंगी. The other side is what they really need to be taught. And I'm very happy when Dr. Madhu Gupta spoke about, going to the grassroots with these messages that the uterus is such an important organ and why it has to be taken out, when there are so many alternative methods. And when I was listening to Dr. Firdaus, her story, I mean, I could make out, how emotionally she was disturbed with that whole episode, being a gynecologist herself. So, we are very commonly, as Dr. Ratna, you yourself face the situation with no offenses meant towards our colleagues who are practicing. But it very often happens, our patients who are being treated in the private setup, they will come with a fibroid which is asymptomatic, which may be 2 or 3 centimeters just lying there. She got a scan done for any XYZ reason, not even a gynecological reason. And then the scan is there and the patient is told you have to have hysterectomy. So the patient comes for a second opinion and you examine and you are astounded that what could be the, possible reason for being advised a hysterectomy. So the patients, of course, some of them do not even bother to come for second opinion, and I suppose they go in for the hysterectomy. But the others who come, then obviously we have to be very careful when we talk about our colleagues. We can't even actually, that is another very delicate thing, because as obstetricians and gynecologists, I think it's part of our training that we must never pull down any of our colleagues. So it becomes all the more challenging to kind of be in the middle path and tell them that at the moment you are doing well. If you are having any symptom, you come back to us, but for that moment you can just avoid this kind of surgery. So definitely, these situations are coming every day. And again, the audit, we have had the guidelines from the ministry. So all kind of, especially the hysterectomies which are done before the age of 40 years are now under the scanner of the government. And we have been told that if you do hysterectomies for these younger women, they have to be very well justified. So we need to be, documenting everything in black and white, very good counseling sessions. And of course, in the emergency, if you have to do because of PPH with placenta accreta syndrome these days is notorious. And when we did our own audit for 1 month, we had done the audit strictly as advised by the Ministry of Health. So we found that 10 to 15% of the women who were less than 40 had to have hysterectomy. But out of that, majority were the women with placenta accreta syndrome. So that is another thing for which the women are losing their uterus at a young age. Another thing which is very commonly seen these days is the AV malformation. So again, we are able to save the uterus with the uterine artery embolization. At the moment in my ward, we have 2 young women who have had torrential bleeding and come to us, but we have been able to save their uterus. So every other day we are getting, these referred cases for saving the uterus. And I'm really happy that the awareness is there about this condition, because it's just like a tap, it will open and they will bleed like anything, and somebody will just do a hysterectomy for them. But the uterus can very well be saved in these cases also.
Thank you, ma'am. And I think you pointed out a very important issue of not just counseling the patient, but the entire family, because sometimes the decisions are taken by family members and not just a woman herself. So thank you for bringing out that aspect. And I would now like to ask my next question to Dr. Ashish Gavde, who is the Country Medical Director for Bayer. And Dr. Gavde, in your opinion, how can pharmaceutical companies help raise awareness amongst patients as well as amongst the healthcare providers and help elevate the visibility of this problem so that more and more people understand why preserving the uterus is so important?
Thank you, Dr. Ratna Madam. And first of all, thank you to the IHW Council for allowing me to participate in this interesting forum. I realize that I am the only male person who's participating in this forum, but listening to all the stories, it rather makes it more critical for pharma to really collaborate with the entire community. It's not only about the HCPs, but also the patient. I mean, I can still remember those were the days when we were, as a pharma community, we were trying not to talk to the patients. There was always some kind of an hindrance because maybe we are dealing with the prescription medicine. It's always looked at as that whether we are trying to promote. But then these kind of platforms, they teach us a lot that there is so much which needs to be done in these areas like disease awareness, education. And here we can definitely work collaboratively with the HCPs as well as the patient bodies. First, obviously, we can support them in identifying the gaps, and that obviously needs to be done at the level of HCPs as well as at the level of patient, and especially the patient advocacy groups. They can really play a critical role in identifying those unmet needs. Once we understand those reasons which are there for those unjustified hysterectomies, then that can help to address those barriers in adopting those alternative treatments. Then comes the education and awareness, and so many of our experts, they have spoken about the education of the entire family and not only about the person. I mean, I still remember how Dr. Kiran madam said that which are the ideal patients for the hysterectomy, that needs to be first understood. Or maybe when Dr. Madhu Gupta madam, she said that which are the various stakeholders in the entire community which can go through this training or awareness program, especially starting with ASHA workers, ANMs, medical community, and that probably with something which can help in creating the awareness regarding those conservative approaches, which may be like hormonal therapies, minimal invasive procedures, or medical devices, which will finally empower those women to make their own informed decisions. So that will be the critical thing in that, and there pharma can definitely collaborate in this creating that education and awareness. Third, which I feel is the most important, is the capacity building, because we are talking about a lot of awareness and education initiatives, but it becomes really difficult for most of this time. These medical fraternity is very busy. I mean, I can own, being myself being a doctor, I can imagine the scenario in a OPD of a government setup where you are sitting there as a lone practitioner and you are surrounded with so many patients trying to pounce on your head. It's counseling is just out of question over there. It's just that how I can at least finish this daily 100 patient becomes the case. So at least there in that scenario, the pharma can definitely support them in that capacity building. And the best thing is you can work closely with Foxy. Foxy has been conducting so many such training programs regarding these proper ways of managing the HMB or avoiding those unjustified hysterectomies. And there we can help them to have those sharing of those best practices, clinical evidence, real life case studies, and that can make it better. So that capacity building will be the thing. Most importantly, the decision making, how we can have the dialogue between the patient and the healthcare provider so that the patient will be in a position to take the well informed kind of a decision making. And last but not the least, which we feel is most important, is the patient education material. Now pharma as an industry can really help to co-create those kind of material, of course after taking insights from the HCPs and after taking insights from the patients. But while we are creating that material, we should be mindful that we have to create a material, of course, that should be in the regional language. It should be very simple to understand. And most importantly, it should be culturally sensitive. So these are 3-4 key areas where we can really collaborate with the HCPs and patient advocacy groups to make this scenario much better for the women.
Thank you, Dr. Gavde. And just a follow-up question, since you mentioned patient education material and counseling, which is an integral part of managing, these kind of situations. do you have any existing patient support programs that you could highlight? And are there any opportunities for either Foxy or for patient groups to partner with you?
Yeah, I'm very much. And then in terms of the patient support program, it can start with simple campaigns like, awareness education campaigns, which can be on hysterectomy, HMB. Again, a lot of material is available on the internet and the search engines. The challenge is finding the right material. And I won't say that particular sites are not providing, but it is more about how do I go and search that. So if we are not able to do, then it becomes a challenge. Then they get into this misinformation from the internet. So rather than that, how we can create those probably sometimes like app development or sometimes the targeted sites which can provide them the right information on this educational material. Then the patient support groups, establishing the patient support group will be very important to create that kind of a safe space for the woman to share their experience, and getting that insights from those women will be very important in creating that kind of a material in case of a patient support program. uh, Telehealth services, that has been spoken a lot, because even the government is supporting a lot in terms of the telehealth services, and which is very important for a country like India, because in our Bharat, it's such a vast country. It's not possible for a selected group of people to share that information with the desired group. So there these telehealth services can really play a critical role in reaching out to those women who otherwise have a difficulty in access, and there that patient support can really play a role. And then last but not the least, what we can also look at it is the access to the medication, because here definitely it's always important to give those medications to those female who need that. Of course, government is doing a lot. Ayushman Bharat has been initiated, and that's really a great scheme. We can see how these newer treatment options also can be included in that Ayushman Bharat, so that we can reach out to more and more such needy females. So that can be the scenario where we can try to support those patient support programs.
Thank you. A lot of insights in those last 2 minutes in terms of telemedicine, telecounseling, access to medication, etc. We have just 1 minute, so maybe I will give an opportunity to all the panelists to quickly share one thought that comes to them in terms of patient-centered care. And I'll start with Dr. Pandey because you gave us a lot of insights. Yeah.
I had unmuted myself already. I was just thinking, but one thing, if as Dr. Ashwini was talking about the telemedicine and that more education provided, I am being a chairperson of medical education committee for I would be very much willing to do such be part of those campaigns of the education, patient-wise or grassroots worker or the doctors. If something is being taken, because it's better to do practically. Of course, ideas are very good, but to implementation is always. And I have this platform of the medical education. So I would definitely like to be a part. That is the most important thing which is coming, because I want to create more awareness of this Preserve the Uterus.
Thank you, ma'am. And I will go now to Dr. Anjali. Any last thoughts from yourself, Dr. Anjali?
Yes, I want to say that when I was younger, there were no alternative treatments that were available for controlling heavy bleeding and menses. So that were quite good and effective. Secondly, there was again the social stigma in the society that you cannot get those treatments done on an unmarried girl. So there must be some other products or something that should be treatment, and that should be an alternative treatment to hysterectomy. That must be there. So these were the things which I felt that time, which was not there. So these are the things that, and obviously the hysterectomy was necessary for me in my case, and I tried each and every therapy, but nothing solved that time the issue except that hysterectomy. If some products like nowadays or medications or more therapies were available, maybe I was not in that position. That is it.
Thank you. Thank you. And Dr. Firdaus, any parting words from you? Ma'am, we can't hear you.
Hi, I'm Farah, not Firdaus. I want in this talk, I have seen hysterectomies happening to people for vaginal discharge. And Mr. Narendra, I went through his PPT, and it was very enlightening to see that for vaginal discharge, hysterectomy is not at all indicated. And in fact, my household health had gone through it. So in today's panel talk, I want to give a viewpoint of why hysterectomies are happening from a gynecological perspective, from the financial perspective, and try to give it a more balance that doctors are not to be blamed always.
Thank you
So
so much, Dr. Farah. We will be coming on to you in our session, which will be starting after this. So I will just hand it over back to Dr. Ratna. Ma'am, if you can just
we'll wrap it up. We'll just quickly hear from Dr. Gupta and Dr. Suri.
No worries. Great.
I just want to say that this is also a matter of right to health of women. So, and the hysterectomies are done as a, these are, women are exploited to earn some money, to have some financial gains also. So that, I mean, that angle is also very, very important. So that should also be taken care of.
Thank you, ma'am. Dr. Suri, from yourself. I think Dr. Suri is not there. So any parting words, Dr. Gavde, Dr. Ashish?
Just a very short thing, empower those women with the right information so that they can choose the right thing for themselves.
Thank you so much. Very well said. And thank
yes.
you to all our panelists. Thank you for joining us for this very good session, and have a good day. Thank you.
Thank you.
Thank you.
Thank you.
Thank you very much. Thank you,
so
Dr.
much,
Ratna.
Dr.
Very
Ratna.
nicely conducted.
Thank
Very
you.
nice. Very
Thank you so
informative.
much. Thank you so much
Thank you.
for inviting.
Thank you.
I would thank all our participants of the second session for joining us today. With that, we move on to the third discussion for the day, which is on the topic of empowering awareness, redefining hysterectomy and reproductive health through the power of influencers. So with that, I welcome all our panelists for this session. I welcome Dr. Deepti Govil, who is Assistant Professor for International Institute of Population Sciences. Ma'am, thank you so much for joining us. I welcome Dr. Niharika Manotra, who is Consultant of Rainbow IVF and Chairperson of Young Talent Promotion Committee for FOXY, and also health influencer herself. Thank you so much, ma'am, for joining for this discussion. I welcome Dr. Farah Adam, who is a physician in Kurwe Hospital and also an author and health influencer herself. Ma'am, so thank you so much for joining. I welcome Dr. Amanpreet Kaur Arora, who is a psychologist, assistant professor at MIT University and consultant at different organizations and health influencer herself. Ma'am, thank you so much for joining. We would also be joined by Dr. Narendra Gupta shortly. He is the public health expert and also Rajasthan convener for Jan Swasthya Abhiyan, and also is a renowned person of the organization Prayas, which has been actively involved in the latest PIL that has been released by the government. He has been working since many years for motivating and spreading awareness around preserving the uterus. So this Preserve the Uterus conclave, it is our third session for the day. It is an initiative by IHW Council and being powered and is supported by Bayer and FOXY. It is a combined initiative for all three organizations together. With that, let us start with this discussion. In this session, we would be talking deep into how can we reach the other different sects of communities around this this concern. My first question is to Dr. Deepti Govil. Ma'am, as an expert in population sciences, how deep do you see this problem of poor menstrual hygiene being in the remote areas of India? And when we look at population of these populations specifically, how big is that issue? As you've also been involved with the research around this topic, please enlighten us a little bit on this.
Thank you, Dr. Sawant, for inviting me to be a part of this wonderful discussion. And thank you to IHW Council to organize the sessions on such a nice and interesting topic, because people are actually hardly talking about it. And so I'm glad that I will be able to contribute something. And very disclaimer I want to give in the beginning itself, because I will be talking purely from the social science perspective and using the research findings from the literature and my own studies. So it is nothing to harm or hurt anybody if I give certain concerns. So we all know that menstruation is considered as a part of women's identity. So what is there to hide about such kind of issues like periods? But still, menstrual taboos and stigmas are deeply rooted in Indian culture. Women and girls are often considered impure, unclean, and cursed during menstruation. And these taboos not only limit females' life, but they are also asked not to enter the kitchen or places of worship or maybe participate in the social events, or not to even wash their hands or hair and even touch the pickle, or even they have a different sleeping arrangements, which leads to discrimination and exclusion. Interestingly, these taboos are repeated from generations to generations, and this scenario is commonly prevalent in the rural India, and even those with more cosmopolitan upbringing are not immune to such attitude. Even we, if you see in our families too, we also experience such kind of discrimination, which happens with all the girls and the women, including us. So the result of these restrictions and the discrimination is a feeling of fear and disgust around the period, and which affects girls' self-worth as they come to associate their bodies and identities with negativity, and further hinders them from talking about the health concerns when they arise during their lifetime. Okay, so the another issue which comes is like the period poverty, which is a kind of a serious concern. So many menstruators from the low socioeconomic households are turning towards the homemade solution because commercially sanitary products are not affordable to them. This particular scenario in turn increases the risk of developing health issues like reproductive and urinary tract infection. So if we pick up the new latest reports, maybe from the National Family Health Survey 5, in India, about 50% of the women use cloth along with the other sanitary products during the menstruation. But if we remove the usage of the other kind of a product along with the cloth, you will find that around 22% women exclusively use cloth, which is not classified as a hygienic protection. So this percentage is much higher among the rural women and women with no education or less education. Even the women from the tribal communities and the low wealth quintile, and many of the less developed states like UP, MP, Chhattisgarh, Bihar, and even some of the northeastern states are contributing to this practice in a very significant manner. So looking into the social sphere, stigma and the poor education about the menstruation and the other reproductive health issues limit the mobility and the social interaction of these women. Okay, so and additionally, women largely ignore the menstrual hygiene and do not prefer to use the modern products like sanitary pads because it is very difficult. It is very difficult for them to dispose, and it leads to the embarrassment. Okay, so whatever information is being imparted to these women, young women, is coming from the mothers, coming from the other female relatives, or maybe you can say the close female friends, or maybe the female teachers. So it becomes kind of a narrow pool for the possible confidence, because these are the people only who can impart the education. But interesting thing is that these people themselves have the limited knowledge and several times make discussion on the reproductive health issue as dirty and impure. Okay, so stigmatizing messages are more prominent type of messages received by the young generation that modifies their ideology, even the psyche, which affects the practice throughout their life, and even the knowledge which they are going to impart to the other people. So again, I would like to quote NFHS 5. Even today, 71% of the girls do not know about the menstrual hygiene during their menarche, which is a matter of concern. So, but more, what I feel is like, who is responsible for it? So one important thing is that there is a limited curriculum on the life skill education at the school level, which creates an inhibition to talk about such issues in the school scenario or premises, also limits the dissemination of the accurate information. Further, limited accessible opportunities restricts these young women's source of information about the menstruation. Though school can be a good source to educate youngsters on such issues in the beginning itself, but increase in the school dropout rate after the menarche restricts their mobility. And as even in the schools, they face shame. Even if they are in the school, they face shame, embarrassment, and a lack of infrastructure to support their menstrual requirement, just like dirty toilets. Okay, and the doors are not able to close down. So these girls can get confined to the four walls of the house as they have grown up, because this is being told by the family, now we have grown up. Okay, and speaking on such issues will bring embarrassment and shame to the family. So externally imposed restrictions and the guidelines on mobility and the social interactions generally shape the reproductive health of the women. As it is a part and parcel of the women's life, women even do not prefer to meet the healthcare provider until unless situation is grave. Even the ASHA worker, who is also very much overloaded with lots of responsibility, cannot contribute significantly on this particular issue. Therefore, gender inequality, discriminatory social norms, cultural taboos, poverty, and lack of basic services like toilets, sanitary products, and the medical attention can all cause menstrual health and hygiene and the reproductive health issues or the needs to go unmet.
Thank you so much, Dr. Deepti, for such a comprehensive answer. You were able to touch upon various points, what you shared, that how deep is the problem, and where in which segments of India you highlighted suffer more from this, and how challenging is this, because this is such a sensitive topic. And greatly, as you shared, it also entirely depends on how the girl is being brought up in the family, what sort of psyche and what sort of thinking she has around this. So before we part you, we have just one more question for you, which is what would be your suggestions for what strategies you would recommend for specifically influencers, health influencers, as people these days, young and even older, are all on social medias. They are constantly consuming content, and also they come across people who are advocating good health in their social content. So what strategies can we adopt using these latest technologies and social media, so as to we promote a culture of more open dialogue around such sensitive reproductive health issues? Because it is not just limited to the poorer regions, but also in people with affluent backgrounds. Whenever they have to go out to buy sanitary pads, they have to get it covered into a newspaper or a polythene bag. You cannot freely carry even menstrual hygiene products for your use, let alone speaking about these topics with your male friends or etc. So definitely, how can we have the health influencing community encourage a more open dialogue, more openness, more frankness, and also I am not able to recall the word, but it would be an platform of equality and equity amongst reproductive health services. So what would be your tips or strategies that you would recommend how to go about it?
Yeah. So first thing, actually, I would like to say that there has to be an open conversation about the menstruation. Okay, not only by the providers or the influencer, it has to happen within the family, within the society, within the community, so that they can normalize the topic and break down the taboos. Okay, even if you talk to the male counterparts, they will feel very shy in talking about the menstruation, which is not actually correct. So it becomes important that sharing experiences and the information to create an understanding and supportive environment for the women and girls are very, very important. So until unless menstruation is freely discussed in the household, the menstrual and the hygiene and any other problem related to reproductive health issue will remain a distant dream. Okay, and we really need to talk to them that what actually menstruation means for a woman. So it does not have only the role to produce children. Okay, it has much more wider function within the human body, which is not just merely restricted to reproductions. Okay, so this kind of information is actually being, you can say there is a lacking among among women about such kind of an education. So it really becomes important that we really need to direct our talks or the studies towards when we talk about the the holistic and the life cycle approach to address the health concerns and improve the women's health status, especially the menstrual health status. Okay. And apart from that, there is a need to provide the counseling and educate women about their reproductive rights and informed choice and promote access to sexual and reproductive health services, which is not at all prevalent, or you can say very limited to a particular segment of the society, not to everybody. So that is all I would like to say.
Thank you so much, Dr. Deepthi Govil. Ma'am, with that, we have Dr. Amanpreet Kaur Arora with us, who is a psychologist and a health influence advocate herself. So we would like to know from her that as we are talking about having this issue with the psyche of the family as well as of the woman, how she's brought up greatly influences how she goes about around menstrual topics and her own menstrual issues. So as a specialist in this region, how do you feel about this? What goes on in women's psyche as to why this thing is still a big taboo in this century, that they're not able to talk freely, and there is a big gap in the open dialogue and openness around this topic of menses, periods, menstrual health, good menstrual hygiene?
Thank you so much for having Dr. Aswari. As Dr. Deepthi was talking about the same scenario, that it's really hard for women when it comes to menstrual hygiene and reproduction situation, because it is still tabooed. It's a stereotypical thing, and we find it hard to speak about. It is because of the previous generation, probably the gender roles that we were given, and also because it's of course it's going to change with having open dialogues, with having open conversation, as you were talking about social media platform, that everybody is consuming it in a very mindlessly also at times, and every age group is there which is consuming social media. So I can, by talking it openly, by having an open conversation, by normalizing it, when we can normally talking about it, when we when we can actually carry a sanitary pads without being shameful about it, because it's a very natural phenomena. It is very, very natural phenomena that we shouldn't be feeling shame. And along with that, I would like to add something over here, being from a psychological background, that as we were all talking about that, there's a shame associated with it, and women are subject to discrimination also. And also there's an impact on their self-worth, their self-esteem. So there's so many other psychological factors, so many impacts of a psychological impact is there on women. And so it is very important that, this discrimination, this low self-esteem, lower self-worth leads to other mental health concerns.
I believe we lost Dr. Amanpreet due to some network problem. So until she joins back, yes, I believe she's back. Yes, ma'am, please continue. Please unmute yourself. Yes.
I'm sorry, it was an internet interruption. Yes, I was just saying that, all these things, discrimination and lower self-worth, all these concerns lead to mental health conditions in later on. So it can lead to stress, it can lead to anxiety, it can lead to depressive symptoms. So it is very important that we empower our women with coping mechanisms. They should know how to cope with stress, anxiety, because whenever they are having these menstruation coming up, they have the stress, they have this anxiety that, they are anxious about. Anxiety is basically, being fearful of something which is not there in the present, but which is coming up in the future. So they become very anxious. Even if the menstruation is not there, they become very anxious about the symptoms they are going to experience. So it is very important that we address those anxious symptoms. It is very important that we make them understand about the stress, the physiology of stress, that how it is related and associated, and how can we deal with it. So I think these are the major concerns that we need to address along with other physiological symptoms, because with major menstruation concerns and issues, these are the symptoms, the psychological symptoms, which are also very much associated, but we are not paying that much attention to these. So for this, we can have more live sessions, we can have more workshops, and where we can address, and we can actually have workshops where we are talking about all the coping mechanisms, where we are addressing the stressful symptoms and depressive symptoms, and also about anxiety.
Thank you so much, Dr. Amanpreet. We have Dr. Farah Adam here, who's a physician and also an avid health influencer. We had a discussion personally before the show, and she has some very strong points around this topic. So, ma'am, you have been watching this show since, the beginning that we are doing. What are your thoughts around preserving the uterus? One, also this problem of prescribing hysterectomy surgeries in unwanted and unnecessary fashion that the government has now also observed is on the rising trend in some parts of the country. So what would be your thoughts on the same?
Thank you, Asavri, for passing the mic. Good afternoon, everybody. I'm Dr. Farah Adam. I am a physician at Kaveri Hospital, and I'm an author of the book Newborns and Newborns. And I'm very happy that I'm getting to read and research about this topic because it opens up new avenues for me. And in my practice, I have seen two cases I want to talk about. One I spoke about in the last session by mistake was about a lower socioeconomic status lady with chronic discharge getting a hysterectomy, unjustified. And now she always has lower back pain, leg pain, and the long-term sequelae are taking hold in her. Another patient I want to bring, this was, I feel, an unwarranted hysterectomy. There's another patient. She, let's just stick to fibroid because I think many of our viewers know about this condition. And we're not talking about the obstetric, the pregnancy-related reasons for hysterectomy. Maybe it can be an uncontrolled hemorrhage after childbirth. I'm not talking about that. We're talking about gynecological issues. So there was a patient with fibroid who came to me and said that my gynecologist is recommending that I get a hysterectomy done. And her hemoglobin had come down significantly low, 6. And she said, I did not want to go for a hysterectomy. So I ate, okay, like, there's a brilliant thing that she did. She ate dates and beetroot juice and got her hemoglobin up from 6 to around 11 to 12, just by eating that. And she's like, I'm fine with the bleeding. As long as I'm not fainting, I'm fine with it. So do I need a hysterectomy for the purpose that, is this tumor going to spread? So I had to reassure her that this is a benign tumor and it is not needed considering her symptoms have abated with the diet. But that brings us to the question, was the doctor unjustified in telling her to go for a hysterectomy? And I want to give not two sides to the story, more than two sides, because it's a very nuanced discussion. And we are talking about experts over here who put patients under the knife, not just for making money, but for the sake of the patient, right? So we cannot always look at the lens that they are here to make money. Yes, there are bad apples in every profession, and medicine more so. So the first thing I want to put a big question mark on is our medical education system good enough to equip obstetricians and gynecologists to not go for hysterectomy? So the more I researched about fibroid management and lifestyle modification, there are a lot of things came up. One, vitamin D deficiency can give rise to fibroids. Another one, uncontrolled blood pressure, insulin resistance. These are all lifestyle diseases. And as you know, the fibroid incidence has increased. The diagnosis has increased. Now, why is that? Is it because doctors want to make a quick buck? No, it has got a lot to do with our sedentary lifestyle also. And suppose if we ask any doctor, I'm not just saying OB, any doctor, that you tell them, quercetin, the phytonutrient found in many fruits, will help in reducing fibroids, strawberry extracts and quercetin. Now, even if it would tell me, I was like, what is quercetin, right? It's a phytonutrient that you see in apples, berries, and red grapes. And it has a brilliant effect on shrinking the size of an already big fibroid. It has shown leiomyomas and fibroids. It brings the size down. Now the question remains, have we been trained enough in lifestyle modification nutrition from the level of MBBS to advise this to our patient? And if so, recommending berries and strawberries and red grapes and apples to the patient, where do we draw the line? But you tried for 6 months, let's move on to a more radical approach because it's not getting better, right? We do not have that kind of training. So it is a responsibility of the people who set the medical curriculum to include these. We had barely 1.5 hours related to nutrition in the whole 5.5 years of MBBS. I'm talking about just MBBS level. Post-graduation, they are so busy that it is not exactly, you can expect them to devote much time to lifestyle modification. That there's a big gap over there. Now I'm going to go on the other side of the debate and say counseling, even for the lower socioeconomic status who are not Googlers like the urban population. They don't Google that much. They don't not that educated to understand what is written in those blog posts and articles, which are like teeming on the internet. So the long-term sequelae, patients are not being warned about that. So there's a risk of bladder prolapse. Urinary bladder prolapse means because the support of the uterus is gone, the urinary bladder can come down. And that gives rise to urinary incontinence. And because the cervix is removed in a radical hysterectomy, the function of the cervix is to produce mucus and protect the vaginal canal from outside invasion. Here, their sexual libido will come down, not just from the psychological viewpoint that they don't have a uterus, but also from a physical viewpoint. Their libido will come down, their lubrication will come down. So suppose a low socioeconomic status lady, because of the heavy bleeding and the dysfunctional bleeding that is happening probably many days in a month, her sexual life has suffered. Will the doctor tell her that your sexual life might not improve that much considering the lubrication is gone, considering your libido will come down? So this counseling is where it is lacking. Again, an OB, anybody who has gone to an OBG, you know how busy they are. They have surgeries to do, they have emergency deliveries, they have lots of things on their plate. So the pressure of the corporate pressure on a doctor, I'm a doctor, I know, there is a corporate pressure on all doctors that itna footfall hona chahiye. You need to have this much footfall. You need to have these many patients. You need to have these many surgeries. So I raise a big question mark on corporate policy. Do doctors get enough time with every patient to give this kind of counseling, this kind of advice? So a woman seeking a hysterectomy to improve her sexual life might not benefit as much as she anticipated, thinking the bleeding is over. Now, getting back to this discussion, there are conservative ways. I'm sticking to fibroid because many people know about it and it gives me a concrete example to stand with. So there are conservative surgical approaches where the uterus is preserved. So there is something called as uterine artery embolization. So the artery, which is supplying the fibroid with all the blood that is coming out as the dysfunctional bleeding, that can be embolized, that can be blocked surgically. Now, hysterectomy, the cost of hysterectomy is under 30,000. The cost of uterine artery embolization, which is a very radical way, is 1 lakh to 2.25 lakh. So when they say that hysterectomy is advised more to the lower socioeconomic status, it's because of the lower socioeconomic status. That is the only surgery they can afford that will give them relief. Myomectomy, where only the fibroid is removed. The myomectomy, it can be done in all these minimally invasive surgeries, the keyhole surgeries, even in the hysterectomy, there's abdominal hysterectomy, vaginal hysterectomy, laparoscopic. There are lots of types. The more advanced the surgery, a keyhole surgery, say for example, a uterine artery embolization, even a myomectomy, which is done very conservatively. Myomectomy's cost is 75,000 and upwards. 75,000 is the lowest cost you'll find. The bed charges and the other sanitary product charges, I'm not even including those. So where is the scope of advising to a lower socioeconomic strata, go for uterine artery embolization, shell out 2 lakhs, go for a myomectomy, shell out 1 lakh? They cannot. If the government can give us enough incentive, if the government can provide the OBGs, like 5,000 mein uterine artery embolization, of course they will go for that, for the lower socioeconomic status. So we are missing out on a very valid point. Before pointing fingers at the OBG, we need to point fingers at who is responsible for them not getting enough time for counseling, but that is corporate footfall. The curriculum itself does not include lifestyle modification. They don't have guidelines for lifestyle modification. We don't have any guidelines. Like berries, kitne dinon tak khane bolo, how many berries to eat, which berries to eat. For example, I gave you, there's just one small example. So in patients with usually socioeconomic status, they have big families, like 4 kids, 5 kids. They have completed families. They do not want the uterus only because they want to avoid pregnancy also. And maybe if an IUD might have failed. IUD is like an intrauterine device that can be used to control the bleeding. So that could have failed and surgery was the last option. And in those surgeries, hysterectomy happens to be the only option for this woman. So here I'm a little bit of not even a devil's advocate. I'm an advocate on all sides right now that we cannot just blame OBGs. We cannot just blame the system. We have to start from the top. Where is the curriculum coming from? What is the corporate doing to the OBG? Because at the end of the day, OBG or the doctor is the one who's going to be assaulted, sued, or a litigation coming their way for an unwarranted hysterectomy. So we need to look into why unwarranted hysterectomies are happening, and there has to be, at the grassroots level, there has to be a change to improve this practice.
Thank you so much, Dr. Farah. We will come back to the points you shared. But before that, I would like to know views from Dr. Niharika, who is there with us. Yes. So, ma'am, you have been following the Preserve the Uterus campaign with us and also have actively participated and been actively listening to the conversation going on. What would be your thoughts and views? On one of the panels with Dr. Bhaskar Pal, he also pointed out that majority of the doctors in their syllabus are taught only few different surgeries, which includes hysterectomy and which majorly does not include the more conservative sort of surgeries for heavy menstrual bleeding. Some of the surgeries he pointed out was normal delivery, cesarean section being one, hysterectomy being another one, and there was one more which I missed out from noting down. But these 4 being the major ones that are taught in the medical curriculum. So what would be your views on the budding doctors, as you are part of the Young Talent Promotion Committee at Foxy? So what are your views on the new gynecologists that are coming out, and how do their thoughts vary around prescribing or not prescribing hysterectomy for some sort of adverse symptoms around menstrual health? Over to you.
Yeah, thank you, Asavri, and thank you, IHW Council, for making me a part regularly for these programs. So as we were discussing about new doctors, see, first of all of you have to understand that our life is not easy. Even after studying for 10 years, I think we get knowledge of about 50% of the things which we are doing. Because as a human body is so vast, and even if you divide our subjects, it would still take us a lot of years to know everything, and medical advances keep changing. So when I was in my post-graduation, we did not have uterine artery embolization. It has come after that. So of course, I didn't know it that time, but I know it now. So we have to understand every few months, there will be something new which is coming up. So as young doctors, we have to be responsible for learning these things or regularly updating ourselves. And that's the only thing which matters. You cannot blame the government or you cannot blame the medical colleges for not teaching us everything. They taught us to the basic, more important education which is required. It is up to us to keep updating ourselves to give best patient satisfaction and outcome. And that's what we all should follow.
Thank you so much, Dr. Niharika. So as Dr. Farah was pointing out, that improving sexual life, and going on to hysterectomy for that reason, especially for women of the rural areas. So I would want to know, ma'am, how would the women from a rural background even be able to share this with the doctor, that just because my sexual life has not been keeping well, I am opting to go for this. I am not sure if they would be confident enough in sharing this to their doctor. We have a good number of female doctors at the lower community health levels, but at the same time there are male doctors as well. and being able to provide female doctors in that number, as shared in one of the panels by a government specialist, is not very practical as of now in our country. So that begins a biggest constraint that, I can see an urban woman being able to freely share her thoughts and feelings with her trusted gynecologist, but I am not sure if a woman from a lower socioeconomic background or somebody living in remote villages where hysterectomies are also high in number would be able to share the same. So I would want to know what your thoughts and views are, and how can we devise strategies and methods so as to reach to that level of population as well somehow. So thoughts from both our specialists over here, starting with Dr. Farah. Ma'am, your thoughts.
This is a very sensitive issue to bring out someone's sexual health. I practice preventive health in my hospital, so all the corporate checkups and all, and I make it a point to ask always about their social history, their mental health history, as well as their sexual health history, because that speaks a lot to me about why certain conditions are happening, why like mental health issues, they stem a lot from these social issues, the sexual health and other family issues. So here the sensitization has to be done with the doctor. The doctor has to be sensitized about this, that every patient, you need to take a thorough sexual history. So because if more and more doctors start doing it, I think it will trickle down and the rural population will be little more comfortable. So word of mouth would work over here in the sense, okay, I went to this doctor, she asked me in detail. The he part, so it's going to be a really long uphill journey for a woman to be able to open up to her practitioner who's a male. But at least with females, we need to sensitize doctors about the importance of counseling, give the entire, if it's improvement of your sexual life is your goal, then hysterectomy might not be the best option for you. And we have to go for a more conservative approach. If the family is completed, hysterectomy is kind of offered on a plate to them. So here counseling and building a rapport, taking the time to build a rapport with the patient is what holds paramount importance. But then again, we come back to the question, do OBGs have that kind of time in their practice? Which the answer is a big no, they do not. So here, maybe a counselor would help, or someone who speaks the local language, to get the sexual history. That would be really helpful. Even if the practitioner is a male, so maybe an ASHA worker or any other such worker can get the sexual history. They know the language, they know the culture of that place. Most of the doctors are like, they've studied in an urban area. They don't know the nitty-gritties of asking such sensitive questions. So an ASHA worker would be of paramount importance over here to help. Just have a counseling. So you get the counseling time also. Maybe that will generate more employment and more ASHA workers also. In addition, that will kind of curb the gap that is there between the hi-fi doctor who is untouchable according to the rural population. He or she is like God for them. Whereas the ASHA worker will be the bridge, like say the priest, which will bridge the patient as well as the doctor communication gap.
Very nicely explained, ma'am. Before going on to Dr. Niharika, we had just sharing a small bit that in the previous panel, we had three patient voices. I won't call them patients, but they have had undergone hysterectomy at some point of life, all three from different socioeconomic backgrounds. One being from a very remote village in one part of Rajasthan, for which we also had a translator to help us understand what she was explaining about her thing. And we could all just understand this, that she has recently been prescribed hysterectomy because somewhere it was causing her loss in her health as well as loss in her finances in some way or form. And this was a justified hysterectomy for her case. But having said that, she did not have any awareness herself of why she was prescribed it, what later post hysterectomy complications she might suffer from. She had no clue at all. The other two cases were from urban cities, so they were able to explain their case better, one being a gynecologist herself who got the hysterectomy very early on, 20 years or so ago. So there the technology also varied from the technology that we have today. So all the allied health therapies that we have in this generation was not so much available in previous generations. Hence, they had to go for hysterectomy ultimately, because having tried everything, the issue was not getting solved of heavy menstrual bleeding. So, ma'am, Dr. Niharika, what would be your thoughts on the same? That, how can we inculcate this awareness and attentiveness in the newer gynecology, fraternity, that to seek different allied therapies and just keep hysterectomy as the very last resort if nothing else is working?
So I have a slightly different take here, and I don't think that, doctors don't give time to their patient. First important thing here we have to understand is that women reproductive health and hygiene in our country is a very awkward conversation. They are not taught to talk openly. It's stigmatized so much that they will even not talk if they even have something very, very huge, or it's something which is risking their health. And this stigma is what we are fighting against. So the most important group which we should concentrate or target here right now are the adolescent. Because if the adolescent community is made more aware of their reproductive health, their reproductive choices, I think the future generations will openly start talking about it, will be more sensitive to the reproductive health, and then therefore they'll be more aware. Unfortunately, our schools in India do not openly talk about sexuality and reproductive health at any class. It's not just younger class, even, I've gone through schools. I'm from a smaller city, and that chapter was always a closed chapter. The teacher would never teach us. And jab wahan, awkwardness is from the teacher itself, it grows through all of us, and we don't talk about it, we don't discuss about it. So the complete absence of a comprehensive sexual health education in India is one of the biggest reasons why we are all facing all this, and why, population doesn't come and talk to us about sexual health, their needs, and we have to work on this so that they can make their right choice.
Thank you so much, Dr. Niharika. And very rightly pointed out from your experience. I remember my experience in school as well. I was taking tuitions from a private tutor who was male. So that particular chapter, he told me, "Ye main nahi padhaunga, ye aapki mom padhaengi." And he skipped that one. I did not understood then, but later on I took biology myself and went through all that, then realized, okay, that this is such a big taboo. I am a small city myself, so I could relate to that sort of mindset. And I feel like awareness, not just in terms of making women aware, but also men aware. So if you can remember, in schools, we used to have, on hitting the age of puberty, all the classes were, taken to have a lecture on periods and women's health. In this, for the specific classes around 6th, 7th, or 8th, something like that. And that specific lecture, I don't know why, was only given to women. Why not the male, students in the class? Because men, yes, do not have reproductive puberty, but if you do not disseminate the right information, how will they know in future for their sisters or their mothers or their wives what is right and what is wrong? If we, being the specialist, are not able to spread the correct sort of information, the sources that they would get information won't be as validated or correct in nature, so that whatever they're learning are just basically myths being realized, or gossips being translated into facts. So here comes the role of our influencers, our health influencers of the country, as well as the upcoming generations of doctors and OBGYNs who are, very active and very vocal, you both being yourselves, that, information that you put out. So my question to both of you next is, how do you balance, as you have seen, as we have also observed in this industry, that when it comes to advocating anything or being vocal on social medias, people are more interested in whatever goes viral, whatever is more entertaining. And when you talk about health influencing, you have to strike a balance between disseminating the right and the correct factual information, as well as making the content very entertaining and easy to grab, with high number of watch list and high virality in nature. So how do we strike a balance between both so that we can reach to as large audience as possible and also make the health community more hip, not just the dance and the food videos that are going on? So starting from Dr. Farah, what are your views, ma'am?
So today only, I was just browsing through Instagram, and there was one reel in which a woman says that we are punished right from a young age for having a uterus, for being able to reproduce. She was talking about menarche and the pain associated. Then we are punished every month by our uterus for not bearing a child. Then when our reproductive life is getting over, like menopause, we are punished again. And you should have seen the overwhelming number of comments below which said, why don't you get a radical hysterectomy? And I was so mentally prepared for this thing. I wanted to just like, can you guys just tune in? But this was a Western thing, so I didn't want to get it. I wanted to pick my battles well and not get into a comment war with some uneducated people. So yes, the fact that boys are not educated is a very big problem. So the thing is, it's a very sensitive issue, especially in India, right? Anything related to female reproductive system is either overtly sexualized or overtly covered. We need to strike a balance in the middle. So I have a significant following of young medical students. So we can keep having, the only way to do is keep talking about it in short format, in a long format, and everyone's attention span is really like going down the drain. So it has to be in a more relatable way. It has to be in a more in a way that makes the person think about it. And it all starts with educating our men, because they are going to be fathers in the future, and they are going to be the ones who will be curtailing their daughters from speaking about stuff and from picking up causes. So thankfully, my husband, my parents, my father, my brothers, they are very supportive in this manner, and they are okay with me talking. So it has to be a complete mindset change, and the health influencers can do their part by just trickling information in a more digestible form to the public. And it shouldn't be like Papa don't preach wala this thing. So yes, health influencers do play a big role in educating them in a more palatable and digestible kind of a way.
Thank you so much, ma'am. Dr. Niharika, ma'am, your views on how can we strike the balance between these aspects?
Yeah, thank you, Sabri. So I think I have a slight change here. First of all, we have to understand there are a lot of incorrect information which is happening on social media. And it is like this Twitter, Facebook, YouTube, Instagram, they disseminate any form of information and it goes rapidly. And you don't even know whether that source of information was correct or not. So the important thing here right now is to be called as a health influencer. People should understand who is a health influencer, whether that person has that basic education to be called as a health influencer. Because when you open Instagram, people talking about hysterectomies, people talking about taking some form of Ayurvedic treatment, homeopathic treatment, weight loss diets, and are actually not educated in that field to even give that amount of information. So as Instagram people also, or as people who are following, please understand your source first. Secondly, as doctors, why I actually came into Instagram was because my patients were following someone who was giving all sort of rubbish information. And I realized, no, I have to stop doing this. And I came into Instagram very late, maybe just 1.5 years back. just to, let my patients follow me and get the information which I want. Because, they come with such vague answers or questions which are funny. So educational content which is going on has to be correct. And I think we have to have some form of body looking after it so that correct information is being spread. We are talking about entertainment. Yes, if you dance right now on what jhumka, it'll go like this. But if I tell you preserve the uterus, I won't get any likes. So I have to use that song in my message of preserve the uterus to get the amount of attention I want. So you have to balance the entertainment with messages, but right message in the right language and for a short duration. So just give the limited amount of knowledge which is needed. The rest they can come and discuss with their doctors. Also having awareness programs like we are doing right now, I think we have to start promoting these forms so that we'll connect to a lot of younger doctors, tell them to start doing awareness programs on social media so that we have expertise talking about situations and not lay people giving advices.
So true. I actually feel everyone is a mental health coach online nowadays. Everyone talks about mental health and whatnot as if they have been trained in psychiatry and psychology. I don't see them venturing so much in the other fields like Aftal Pakadlo, OBJ Pakadlo. They don't go that much. Mental health, everybody is an expert. So I completely agree with Niharika. There has to be some regulatory body that give some validation to the doctors that this is a trusted source and this is not a trusted source, and don't go for that cabbage diet and that is going to cause you more harm than good. Like only harm, actually, not much good. You'll just lose like a few kilos in the beginning, but it's going to come later on and bite you. So yeah, it's a very important thing that people need to recognize who are the right doctors to listen to. And anybody can put a DR in front of their name on Instagram. Anybody.
Yes, I completely agree.
Anybody can become a doctor. And
so
there's no
on
one
the
to question
same note,
them.
I was about to share this after Dr. Niharika what mentioned, and now you rightly pointed it out, that I literally fell for one of these pages. I followed them thinking it was written your food doctor, your PCOS doctor, something like that. And I thought he was an endocrinologist or a fitness expert or something like that with a specialization. I followed, but when I got more interested, I looked into his background. And no doctor at all, just a normal someone else, but being very popular and calling himself as a doctor and giving out medical, food, nutrition, all sorts of advices. And I was like, how can you just write a DR in front of your name when you are not one? So as rightly pointed out by Dr. Farah, that you do need some sort of body that not just from a medical, government perspective, that regulates this kind of information that is being passed around. Because this is very fresh with us. During the COVID, we got so much information disseminated that these are the COVID remedies, these are the COVID pills, these whatnot, and people made billions out of that. Even selling fake drugs and stuff. To which extent the government has regulations on selling stuff, but what about the regulations on selling content? And putting out those sort of information which is not validated, not correct in nature, or is coming from a source which is not a specialist in that field. So I believe this awareness needs to be generated through people who are actively, vocal on health communities, us, as well as basic awareness in friends and family, that make sure whoever you are listening to has some sort of experience in treating your sort of concerns. As human body is so wide and complex, one size does not fit all. So whatever worked for one person does not mean that you just actively start advocating it, and everybody who is following that would his diseases would get solved. So definitely that sort of some regulatory body needs to be there. Also, we were talking about, Dr. Govil was talking about upbringing, how upbringing and psyche of women are developed since the childhood. On the same note, the psyche of men in Indian community also gets developed from the very childhood. They see their fathers not talking about these issues with their mothers. Hence, they have this notion in their mind that this is not something to openly talk to your wives or something. So when shit gets real, when they have to suffer it themselves with their, wives or spouses, they do not know how to handle such situations. Hence, we have those families who are advocating that, we do not want our wives to suffer from this heavy menstrual issue or some other sort of reproductive issue, and we want you to get hysterectomy done. And wives, not being the dominant person in their family, has to give in to their family's expectations and opt for hysterectomy. Again, the cost issue that Dr. Farah highlighted, that getting a hysterectomy surgery at many places is cheaper than the allied health therapy options, which require expertise from the doctor's side as well as expertise in healthcare infrastructure, which is not available, especially in remote areas and also in certain parts. I remember one of the patients sharing in the previous discussion that she had to travel from Bhopal to Jaipur just to get an allied therapy done because her age was very less and she was unmarried. So she couldn't go for hysterectomy, which was the only, possible option, and had to go through other allied health therapies which were not readily accessible that time in every city. But now as well, after so many years, we see this not being the case, that in rural and remote parts, you do not have GYN specialists, in large number. And the doctors that are seeing all the elements are MBBS, although trained, but not a specialist again. So, and so also the advances in technology are lacking. And again, as rightly pointed out by Dr. Niharika and Dr. Farah, that creativity is required. That if a viral song is going on, people would have so many likes on that, or a fashion video, and not so many likes on the healthcare content being put out. Again, as rightly pointed out by Dr. Niharika, we need not make our social media channels as the one-stop shop for every disease under the roof. We can just disseminate the basics of health information and then maybe just share our practicing details for, specialized care and delivering, unique care to every patient that is there. On the very same note, we come down to the end of this very insightful discussion in which we were able to discuss how we can empower awareness with around menstrual health, reproductive health, heavy menstrual bleeding, as well as taking help from health influencers so as to reach out to as many people as possible. What would be your ending remarks for this discussion from Dr. Farah first?
Firstly, thank you so much for making me a part of this. And secondly, my ending remarks are the same, pretty much same as my starting remarks. The influencers right now will be able to influence the shape of how the psyche develops of an adolescent girl. So we have to use that power and our voice quite responsibly in enabling not just girls, but also boys. That comes down to us to educate them, because the school system is not going to change in the near future. And the second thing is, before we remove the contact number of a lawyer to sue a doctor, we need to probably have a session and find out. Like, for example, my cesarean, many patients who have had cesareans, they feel that there is a very unmet need, that they feel that they failed as a mother. Talking about cesareans over here. And just going and having a chat with their OBG to understand, was it that necessary? Because at that time, it's all like everything is happening so fast and just get the baby out, the baby is going in distress. That could have been the scenario. Similarly, for hysterectomy also, we need to have a long-term sequelae program that in case the hysterectomy is needed and it is done, or even if some might disagree and say it was unwarranted and it was done, long-term sequelae need to be addressed, and there has to be an ongoing program to address that, the long-term sequelae, to manage those, to do pelvic floor rehabilitation of the woman who just had a hysterectomy. And then again, it all boils down to one thing: more sensitization of medicos for lifestyle management of diseases, more focus on these things. Maybe there is right now probably is a right time to educate or have specialists in lifestyle modification alone, because that is pretty much the root of 90% of our ailments in this day and age. And the grassroots level, at that when we are going at the public dissemination of information, schools, they need to have a better approach in educating. Yes, please separate the boys and the girls, no problem. Period talk is hard for the child to absorb and for the teacher to give. Separate them, but educate the boys also about periods and reproductive health and what all they will see in their life once they grow up.
Thank you so much. Dr. Niharika, ma'am, your thoughts.
So I'll just end it with a important line, which I feel that, promoting and disseminating trustworthy health information is something which is very crucial for governments, health authorities, and even clinicians to actually outweigh that false and misleading information which is now getting disseminated on social media and affecting all our practice negatively. So focusing on providing correct information on social media should be our aim.
Thank you so much, ma'am. On that same note, as Dr. Farah said, that the school structure is not going to change for near future. Ma'am, we would advocate, and through our voice that we have in this platform, we would want the structure to incorporate the counseling, not just for female adolescents, but also for male, students, so that whatever information that they are getting from the school is validated. At least later on, maybe whatever they learn from the society is different, but at least their education is being proper, as well as incorporating the more sort of conservative therapies to opt for before going for hysterectomy in the medical curriculum would also need to be advocated, as well as working with psychologists and stuff, so that the psyche of the newer generation is not just one-dimensional, but they are able to absorb and appreciate the pros and cons of all different health situations in a neutral fashion. Yes.
In addition, one more point I want to add over here. Now that we are talking about changing the structure of the education we're giving to adolescents, one very important thing I think we need to teach all students is do not cyberbully. Okay, that is one. Because if a girl, like that was just a fun reel that I mentioned about, right? That woman whining about we're being punished by uterus all through our lives, right? Now, a boy coming and saying, get a radical hysterectomy, somewhere he has planted a seed in some woman's head that I don't want to have kids. Probably she's a young, in her 20s, and I don't want to have kids in the future. I'm a career woman. I will go for a hysterectomy because this period is debilitating for me, right? So this kind of irresponsible comments, which is also a form of information. You don't have to be an influencer to disseminate information. Even the comment section, people, it's like fun for people to just go through the comment section. So we need to sensitize people that use your voice responsibly. Even as an audience, use your voice responsibly. And we need to sensitize the males and females both about it, that you don't need to pick up every battle on every reel. Ye comment karna hai, I need to get into a fight. That's a colossal waste of time. If it's not a discussion, if it's not intended to be a fruitful discussion, that are just shaming. Like the period information with so many guys is so bad. Like they would say that, why can't you girls just hold it in? Like, how you hold in pee, that way. These kind of things. So we need to address these things also. And the curriculum really needs to include how you behave on the internet also as a part of an upbringing for a child.
Definitely, ma'am. Right information, right support, and right resources. All three are very much required in this regard, as we can see from all the discussions. And as you rightly pointed out, on social medias and on the influencing community, if you are talking about any sort of social taboo topics, such as IVF or such as, different forms of period issues or menstrual issues, those specifically do get lots lots of comments and opinions from all sorts of random people, and some people also take that as valid information, not knowing the real thing. So that, and also ending it with, advocating for better health infrastructures at all different levels of the country, so that the lesser fortunate women or the women from low socioeconomic backgrounds also get, these allied therapy options made accessible to them at a nominal cost, so that they do not have to reach out for hysterectomy just because of financial reasons. So that as well. With that, we would like to close off this session. I thank all our participants for joining us, Dr. Deepti Govil, Dr. Niharika Manotra, Dr. Farah Adam, Dr. Amanpreet Kaur Arora, for taking time and sharing valuable insights in this discussion. With that, we also thank our the initiative IHW Council, Bayer and Foxy for this brilliant initiative of taking the mission Preserve the Uterus forward. Thank you so much. I would also lastly thank all our viewers for staying with this with us till the very end. Thank you so much. I will sign off now. Stay happy, stay healthy. Thank you so much.
Saurabh?